How was it?
It is 5:10. People are waiting.
And we are live now.
Yeah.
Please also assist the people who are waiting to join. Yes, Monica, you can go ahead.
A very good evening to one and all the respected faculty members and all the delegates who have joined the program. We welcome you to episode 2 of the Public Awareness Committee FOGSI webinars with the South Zone. This initiative has been taken by the Public Awareness Committee to bring an awareness in day-to-day issues.
Kasa manali?
For each beginning, let us seek blessings from Lord Almighty. Can we have the inauguration slide?
Vashish, please mute everyone.
Like it.
Yes, sir. Speaker.
Slide, and can you please mute everybody else?
Click करके कर भाई.
With each beginning, we seek blessings from Lord Almighty. I request Dr. Bai sir, Dr. Jayam madam, Dr. Sampat Kumari madam. Dr. Raghavendra Prasad sir and Bharti madam are conveners for this program, being the South Zone coordinators. I welcome each and every one of you to this webinar. I take privilege to introduce Dr. Priyankur Roy, who is the chairperson of Public Awareness Committee FOGSI for the current ongoing year. These webinar series are a brainchild from him. Can we have the slide, please? He is also the India representative. Please, last slide. You do not skip slides unless and until told. He is also the India representative at WATOG and SIGO. He is the Joint Secretary of Justice Chapter India, and he is also the National Coordinator for Perennial Committee FOGSI for the last year. We welcome you, Priyankur, and can you please welcome all the delegates?
Thank you so much, Monica. Good evening, everyone. Gives me immense pleasure to welcome all of you to this Public Awareness Committee initiative. And today we are doing this program with the South Zone with the Corona Remedies, that is the COR-Connect live webinar that we're having. I'm indeed thankful to the President FOGSI, Dr. Rishikesh Pai sir, Secretary General Dr. Madhuri Patel ma'am, Vice President Dr. Alka Pandey ma'am, and our National Coordinator Dr. Kalyan Barmade, who was the chairperson for the last year, and I was lucky to take over from him as the chairperson. I would thank the coordinators, Dr. Monica Umbardan and Dr. Shatabdi, who have worked immensely to the success of this program, and a lot of the faculties who have been invited have been done by them, and they're putting really hard work in this webinar. The conveners, of course, Dr. Bharti Rajshekar ma'am and Dr. Raghavendra Prasad sir, who have gone in and invited our faculties as well, and they were the ones who have got the South Zone together in this webinar as well. Our guest of honors today are indeed people who I respect a lot, Dr. Jayam Kannan ma'am and Dr. Sampat Kumari ma'am. And Jayam Kannan ma'am is like a motherly figure, and she has been there behind blessing always in all the programs and joining in all the programs. And that's indeed a matter of pleasure for me and for all of us that she has joined us today. Sampat ma'am, she is again, she's currently the vice president, and she has also been a great support. She has always supported and she has always given tips for the betterment of all our programs. So Sampat ma'am, thank you so much for joining us today. Our scientific session, we have a talk by none other than Dr. Jaideep Tangsa, and he's going to talk on amendments in MTP Act, a talk which really mesmerizes me whenever I hear it. And the chairpersons, of course, Dr. Charmila ma'am and Dr. Vidya Thomi ma'am, another couple, two stalwarts from the South Zone and people who academically excel and who we look forward to. The panel discussion, we have our moderators, Dr. Bharti Rajshekar ma'am and Dr. Girija ma'am, expert being Dr. Kasturi Donimat ma'am, the president of Kasoga, and our panelists, Dr. Rupa Prakash ma'am, Dr. Shamma, Dr. Swarupa, Dr. Rajalakshmi, Dr. Maya Malya, Dr. Pushpalata, Dr. Sabita, and Dr. Sati Muradi. I welcome all of you to this program. And the second panel, a very interesting panel on cafeteria approach for contraception, to be moderated by Dr. Rekha Rajendra Kumar and Dr. Raghavendra Prasad sir, and the expert being Dr. Shobha Guri ma'am, who has been heading the contraception committee, and she's an apt expert for this panel. And the panelists are Dr. Rehana, Dr. Deepashri, Dr. Joylin, Dr. Shushma, Dr. Indra, Dr. Omana, Dr. Sangeeta, and Dr. Radha. So I would like to thank all of you for joining this program and welcome all of you once again. I would also like to welcome the Corona team for joining us this program and for helping us in this initiative, which I'm sure we are going to continue for this entire year. So the plan that we had made for this webinar was to select a topic for a couple of months and conduct a webinar once in every 15 days, including each zone, that is North Zone, South Zone, East and West Zone. So 4 programs for the topic that will be covering the entire, all the zones that is across the country, and move on to the next topic for the next couple of months, and so that we can cover 6 topics in this year. That is the plan that we continue. We will be having this program and we will be continuing this program throughout the year. That is every Thursday, every alternate Thursday, 5 p.m. onwards, and we will continue this program. So I request all of you who are there with us today to kindly spread the word. Every alternate Thursday, 5 p.m. onwards, we will be conducting these programs, and we request you to kindly join us because your inputs are very important for us. Thank you so much once again for joining us. I will not take any much more time, and I would like to hand over this session back to Dr. Monica, who is the coordinator for the Public Awareness Committee, doing excellent work already, and she's also the Public Awareness Committee chair of the AMOGS. So welcome, Monica. Thank you so much for coordinating the whole thing, and thank you, and please take ahead this program. Thank you so much.
Thank you, Priyankul, for the kind words. I now take honor to introduce my co-coordinator and convener of this program, Dr. Satabdi De. She is a consultant at Nova IVF in Siliguri. Please change the slide. She is also over enthusiastic, and she has equally worked towards the betterment of Public Awareness Committee, FOGSI. I request our guest of honors today to join us. Can we have Dr. Jayam slide, please? Vashish, next slide, please. Dr. Jayam, madam, slide. Next, please. Next slide, please. Next. Next. Next.
Yes.
Dr. Jayam Madam is an emeritus professor in Tamil Nadu MGR Medical University. She has been the vice president of FOGSI in 2018. She also holds a certificate course in reproductive medicine FOGSI since 2012 in her institute. She is the president of Indian Medal for Outstanding Performance in MBBS, and she was the first in MBBS in her state. She has received the A.L. Muralidhar Award in MD OBGY. She also holds the title for Best Book in Medicine Award 2 times from the government of Tamil Nadu, and she has authored and co-authored many journals. She has also received the Best Society President Award, Trichy, 2013 FOGSI, and the Best Society Secretary Award at the Tavanjur Society 1988 FOGSI. We welcome you, ma'am, and can you please shower your blessings for this webinar, ma'am?
Yeah. Thank you very much for inviting me to the first one. Am I audible?
Yes, ma'am.
Yes. Yes. My dear child Priyanku and the other children, Monica and others, I don't think it is a meeting of the South alone because it includes Mumbaiite, Mumbaigar, Monica. That means we are putting it as a zone, but you are from the East and there are speakers from the North. So it is a all zone. We are one Indian, we are one FOGSian. That is how we have to communicate with the public, making them feel all at home, all at India, and all at one place in India. I think Public Awareness Committee, Priyankur, it's nice that you have put all people like this. Continue to do it like that in the rest of the, probably another 3 sessions also. Priyankur has been doing enormous work right from the day he took over as the committee chair and even before it. I'm now finding that he is attending even 2 meetings a day in spite of so much of heavy work that he has got. And coming from the neck area of the east of India. The public awareness is one part which every FOGSian, every obstetrician or gynecologist need, because unless you have a link with the public, you require all the social medias for your name to be kept. Whereas if you have your patient who is able to get satisfied and go out to say, go to this madam, go to this doctor, she will definitely be at service to you. That is the public awareness that every obstetrician has to give. And I hope Priyankur will give all the tips and tricks to get into the heart of the public so that we are able to get the reproductive system better in those people. I really enjoy the talk of Jaydeep Tank every time on MTP. As Priyankur said, he really mesmerizes. I'm even eagerly waiting for the second talk also. Thank you very much. And for all of you, I give you the pranams and I will have the best prayers, including all of these public awareness committee people at 6 o'clock Aarati today at the Trichy Shirdi Baba temple. Thank you. Sai Ram.
Thank you, ma'am.
Thank you
ma'am.
so much. Thank you, Jai ma'am, for this wonderful words. It means a lot for us. You have always guided us, and especially have always guided me as a child, and that's what you have called me always. And it means a lot, ma'am, for us that you have joined us today for this first webinar from the South Zone, and as you said, maybe from the country, the first webinar that we are doing today. Thank you so much, ma'am, for your blessings.
Thank you. Thank you.
Thank you, ma'am, for your blessings. I now request Dr. Shatabdi to introduce Dr. Sampath Kumari, ma'am.
Yes. A very good evening, a very warm welcome to everyone. Slide, please. Yes, I take immense pleasure in welcoming Professor Dr. S. Sampath Kumari. Ma'am is the Chief and Head of Department at Muthukumaran Medical College and Research Institute at Chennai. She is the FOGSI Vice President elect for 2022. She is the Founder Secretary of TNFOG. She is the National Correspondent for our FOGSI India Journal between 2021 and 2024.
Shatabdi, you're not audible.
Shatabdi logged
I
out,
think a
guess,
network went off. Priyankur introduced, no? Otherwise, I
Yeah,
think
Monica.
Monica.
Ma'am is the Vice President of the elect for the year 2022. She has been the Founder of TNFOG. She is also the National Correspondent Editor of the Journal of Obstetrics and Gynecologists of India 21 to 24. She has also been the Senate member of the Tamil Nadu MGR University from 21 to 24. She has many national accolades to her credit. We welcome you, ma'am, and seek your blessings for this webinar.
A very warm welcome, ma'am.
Thank you, Dr. Monica and Dr. Sadapti. First of all, we should congratulate Dr. Priyankur, who is the pet child of everyone. So he is a very, very hardworking person with, I don't know how he is able to manage all the needs of all president, secretary and the committee chair. Now he has taken this COR-Connect, the first topic being the MTP. First of all, I thank our President, Dr. Rishikesh Pai, who has given permission to conduct this program, and the guest of honor, Dr. Jayan Kanal, who is a mentor for me. From her only, I was doing the adolescent work. That time itself, we will do with the public awareness committee programs also. And the coordinators, Dr. Bharti Rajshekar and Raghavendra Prasad. And you have the wonderful topic of MTP, where you have the what are all the safe methods for high-risk pregnancy and MTP amendment, as everyone was telling this repeatedly. It will be great to hear from Dr. Jaydeep and the cafeteria approach for the contraception with good speakers and the moderators and panelists. I wish the success for this program webinar, and it should be continuing as Priyanka told once in 15 days with all zones. As Jayam told, it is an all India program and all FOGSI. Wish you a best success. Thank you.
Thank you so much, ma'am. Thank you for your blessings.
Shatabdi, we can move forward with the panel discussion till Rishikesh sir joins, and then once sir joins.
Yes.
Sir is actually trying to join, but I think that password is, again, he's finding an issue with that. So let us go ahead. Let when sir joins, we'll take his blessing in the meantime.
Right. Thank you all. Thank you, Jayam ma'am, and thank you, Sampath Kumari ma'am. We will now go ahead with our proceedings. We will start our first panel, that is the cafeteria approach for contraception. Slide, please. Rajan. Kindly introduce Dr. Rekha Rajendra Kumar ma'am, slide, please.
The next second panel, please. Versus
Second panel.
Panel number 2 versus.
Yes, ma'am. Yes, ma'am.
A little faster. Your net is slow from your end also.
Ma'am, I think there is some issue with network.
Yeah. The
Yes.
next slide first.
So, a very warm welcome to, Dr. Rekha slide. Yes, we have two very eminent moderators for this panel. We have Dr. Rekha Rajendra Kumar ma'am and we have Raghavendra sir. Dr. Rekha ma'am is the medical director of Miracle IVF Hospital and Chandana Hospital, Bangalore. She is a diploma in human resources development, diploma in hospital management, as well as diploma in hospital administration. She has various awards and achievements to her credit. She's a practicing gynecologist for the past 31 years, and she is the president-elect of BSOG between 2023 to 2024. She has more than 15 articles and more than 15 articles and case reports, poster presentations to her credit. So we welcome you, Dr. Rekha Rajendra Kumar ma'am. Our next moderator is Dr. Raghavendra sir. Can we have the slide, please? Yes. Our next moderator for this panel is Dr. Raghavendra Prasad. He is the Director of Infertility and Feto-Maternal Unit at Sunrise Hospital at Kannagad. He is the Executive Director in ARMC IVF, Mangalore. Next slide, please. A very warm welcome to Dr. Raghavendra sir.
Thank you.
Ma'am, Dr. Rekha has joined.
Yeah,
Yes.
I joined just now.
Welcome, ma'am. A very warm welcome to you, ma'am.
A very warm welcome, ma'am.
Can we have the expert? We have Dr. Shobha Gudi ma'am as our expert panelist for this panel discussion. She is professor and HOD at St. Philomena's Hospital at Bangalore. She is a postgraduate teacher and examiner. She has been the chairperson of the Family Welfare Committee of FOGSI between 2019 and 2022. And she was also the president of BSOG between 2018 and 19. She is the author and she has many publications to her credit. So we welcome you, Dr. Shobha ma'am, as our expert panelist for the session. Can we have the panelists' names one by one? We will now welcome all our eminent panelists for this session. Yeah, can we have the CV slide for the panelists, please? Yeah, our first panelist for this session is Dr. Rehana Begum. She is a senior obstetrician and gynecologist at Sumaiya Hospital, Khammam. She is the secretary of the Khammam Obs-Gynae Society, and she is the past secretary of the IMA Khammam. A very warm welcome to you, Rehana ma'am. Next slide, please. Our next panelist is Dr. Ex-Major Deepashri. She has served the Indian Army as an Army Medical Officer for 5 years between 2006 and 2011 and retired as Major. She's currently the Assistant Professor of Department of OBGY at RIMS Raichur and currently the Treasurer of the Raichur Obstetrics and Gynecological Society. Welcome, ma'am. Next slide, please. Next, we have Dr. Joylene D. Almeida. Dr. Joylene is an associate professor at Father Muller Medical College, Mangalore. She was the university second rank in postgraduate exams She is a practicing obstetrician and gynecologist and UG and PG medical teacher since 2011. Welcome, Dr. Joylene. Next, we have Dr. Sushma. Dr. Sushma has a diploma in reproductive medicine from the 21st Century Hospitals at Surat. She is presently the secretary of Raichur Obstetrics and Gynecological Society. She is practicing as an IVF specialist and director of Sai Fertility Center, Raichur. Welcome, Dr. Sushma. Next, we have Dr. Indira Pai Shanbag. She is a consultant obstetrician and gynecologist at City Hospital, UDP, and she is also the treasurer of Manipal Obs-Gynae Society in 2023. She is a master trainer for our FOGSI Dhira initiative. Welcome, Dr. Indira.
Thank you.
Next, we have Dr. Omna Madhusudanan. Madam is the head of Department of Obstetrics and Gynecology at Vinayaka Hospital at Wayanad. She's been working in Wayanad district for the past 35 years. She's the founder, president of Wayanad OBGY Society and president of the Wayanad OBG Club for the last 15 years. Welcome, ma'am. Welcome, Omna, ma'am. Next, we have Dr. Sangeeta Menon. Dr. Sangeeta ma'am is a professor in the Department of OBGY at Government Medical College, Alapura. She has a career spanning 25 years in medical colleges and has been filled with academics and teaching. She is an active member of the medical education unit. She is also an assessor for the confidential inquiry into maternal deaths in Kerala state. Welcome, Dr. Sangeeta ma'am.
Hello.
Yes.
Yes,
Welcome, ma'am. Next, we have Dr. Radha. Next, we have Dr. Radha. She is the General Secretary of the Karimnagar branch of FOGSI. She has a fellowship in fertility from Oasis Infertility Hospital. She is currently working as a chief consultant at Sai Hans Hospital for fertility and laparoscopy at Karimnagar, Telangana. Welcome, Radha ma'am.
Dr. Rupa mute ಮಾಡ್ಕೊಳ್ಳಿ.
Hello, yes. So now I hand over the podium to Dr. Rekha ma'am and Raghavendra sir for carrying out the panel.
Yeah, thank you so much for including us, Ms. Shatabdi. Thank you, Dr. Monica. Without wasting much time, we'll start. Me with my co-moderator, Dr. Raghavendra Prasad, are taking forward the first panel. The panel is on cafeteria approach to contraception. Welcome our expert panelist, Dr. Shobha Gudi, as well as our esteemed panelists. So the panel is on cafeteria approach to contraception. Next slide, please. Hello. Yeah, our esteemed panelists have been introduced. Next slide, please. Since I had problem in joining, I shared the PPT to them so that they will post it. Okay, please share. Please post the next slide. Please keep moving. Take the commands as early as possible. Okay, now the question will go to Dr. Rehana. Dr. Rehana, you're there?
Yes, ma'am.
Yeah, Dr. Rehana, I'm Dr. Rekha Rajendra Kumar. I'm here with Dr. Raghavendra sir. The question first to you is, what are the characteristics of the ideal contraceptive? Since we are talking about the cafeteria approach, if one considers as a contraceptive, what should be the ideal one? What are the characteristics it should have?
It should be easy for her, and also it should not have any risk factors.
Anything
and
else?
Compliance and patient compliance, taking it daily or using it in a proper way without losing the doses in between, ma'am.
So that failure rate is much less.
Failure rate should be very less.
Then next slide, please. Yeah, please proceed. Please proceed.
It should be safe.
Yeah.
It should be safe, 100% effective, free of side effects, easily obtainable, affordable, and acceptable to the user, free of effects on her future pregnancies.
Yes, this is what they ask. Many of them do ask us, right?
Yes, ma'am.
Especially with IUCDs and OCPs, many of them do ask us this question. Okay, next slide, please. Okay, can I go to Dr. Deepashri? Hello? Dr. Deepashri? Dr. Joylene?
Ma'am, Deepashri madam is still trying to join in. You can ask
Okay.
whoever is there.
That is why I'm saying Dr. Joylin. Anybody can answer. Let us not waste time because we have only 45 minutes in hand. Can I ask Dr.
Madam,
Yeah.
what I feel is contraception is actually prevention of conception. When it comes to family planning, it seems when the family can decide how many children they should have and what is the spacing in between the children, there is actually a real difference between contraception and family planning, ma'am. Because contraception may not be in a family.
Yes,
Even without family, now, especially the youngsters in the, adolescent youngsters wants contraception before they become family. But when you come to a family planning, it is really decided by husband and wife when they should have children after marriage. What is the space between the children? How many children do they have? Whether they want temporary contraception or permanent contraception. I feel there's a main difference between the two, ma'am.
Yes. Yes, family planning versus next slide, please. Family planning is exactly planning your family. Like when you want, when you don't want to have, it's welcoming a baby also is a part of family planning. Whereas contraception is just preventing that pregnancy, isn't it? So contraception is the intentional prevention of pregnancy. Whereas family planning is the contraception comes under family planning. It allows the individuals and couples to anticipate they can have it whenever they want. It's a tailor-made thing. It's a spacing, timing, don't want, this time we want. These kind of things come under family planning, isn't it? Dr. Omna, am I right? Hello?
Yes, ma'am. Yes, ma'am. You are very correct, ma'am.
Please keep your laptop unmuted so that you can answer.
Ma'am, if we can interrupt just for a minute, Rishikesh sir has joined us.
Okay, okay, fine. Fine.
I'm sorry for the faculty. Just give us sir has joined us and he is outside actually, and he got his connectivity now and he has joined us. Thank you, sir, for joining us.
Now should
Monica?
we switch off?
Okay. Yeah, just give us a couple of minutes.
Yeah.
Monica?
Sir, welcome. Welcome to the Public Awareness Committee, episode 2 with the South Zone Societies. I would like to introduce Priyankur. You would like to introduce sir first?
Yeah, no problem. Sure. Sir, yes, sir. First of all, we would like to, on behalf of the Public Awareness Committee, wish you a very happy birthday, sir. We are indeed happy that you have joined us today, and thank you so much for being here. And sir, of course, can I have the slide, please, Vashish? But I'll just go ahead. Sir is, of course, the president of FOGSI currently, and it's definitely a pleasure to be with sir always. He's the medical director of Bloom IVF Group, administrator of the FOGSI Manyata Initiative, and a director of corporate affairs IFFS. He has been the president, I would say, of most of the organizations across the country and also organizations abroad. And he has been awarded the RCOG Fellowship. And he's been the past secretary general and other various posts of FOGSI. So welcome, sir. Happy birthday once again. We have made a short video for your birthday. Monica, if you want to go ahead and play that. And we also have Jaideep sir with us. So Jaideep sir, it's a pleasure that you have joined us too. And we really take, Sampath ma'am is there. There's Jayam ma'am also with us, the guest of honors. And we all take pleasure and pride in wishing you a very happy birthday on behalf of the Public Awareness Committee today, sir.
Happy birthday, Rishikesh.
Thank you. Thank you.
Please play from the beginning. Yeah.
Thank you.
So here's wishing a very happy birthday to you, all of us from Public Awareness Committee, sir.
Thank you, Priyankur. One of the, the Public Awareness Committee has become a very dynamic committee, and under Priyankur and before the predecessor, Dr. Kalyan Barmade also did a great job, and I'm sure that Priyankur will continue the good work that Kalyan did. Public awareness, and all of you are there already. A lot of senior people are there. Dr. Madhuri, Dr. Alka Pandey is our Dr. Sampat Kumar is there from the this thing from the she's in charge of the South Zone societies, and we have got Dr. Rekha Rajendra Kumar is there, Dr. Mona is there, Vinayaka, Dr. Monica Umberband is there, and a lot of other people I can see. Of course, the incoming president, Dr. Jaideep Tank is also there, and it's a dynamic. And I think one of the topics today is the topic on MTP awareness, which is very close to his heart as well. So awareness is a very important part of my whole FOGSI. You know that my FOGSI Badlav is there, and the Ekikaran, that is integration, and the next part of it is Samanta, that is equity. And so in Ekikaran we launched the concept of the Yatra, where we did a lot of integration, and it was a 360-degree Yatra where we had the camps in the morning, public forum, and we also did the CMEs in the evening. So we had total integration, and also I integrated the different concepts of health in women healthcare, and in equity, that is equality. It's still a large challenge. So rich and poor should get the same care. And also we have launched the new concept of Samanta in gender equality, which we have launched, and we'll take it to a large level, and hopefully it will be continued. And the third part of that, one of the parts which we launched recently was the cancer service initiative, which I called Pratibandh. So that was also a very big success. Nearly 60 societies participated, and we are doing it on a large scale. Our Badlav clinics, which are our endpoint through which we will be implementing all our programs, are on the cards now. Everything is going well. And so the last 3 months have been very hectic, and hopefully the next 3 months will be equally good and impactful. And we all do everything because we want to feel happy inside us. So it's very important. Few important things that I would like to say here is that there are many conferences coming, and you should all participate in full force. There is the problem because a lot of people want to do conferences, so there may be an overlap, but our country is very large, and I don't think an overlap is really going to impact a particular conference in any way. So anyway, I'm really grateful to Priyankur and all of you, and I'm thankful for you to have called me today and wished me on my birthday. Every year as it passes by, you realize that you're becoming more and more mature, and you become more and more younger as well in your thought process. So thank you very much, and wish you the very best, and hope that you have a fantastic academic interaction. Thank you, Priyankur.
Thank you so much, sir. So as was the wish of yours, like public awareness for the public as well as for the doctors, the new updates and all that we need to bring to them. So as we are discussing today, so the MTP Act amendments which Jaideep sir will talk, and we are doing 2 panels, one on making MTP safe and the other one on cafeteria approach in contraception. So we are trying to bring the recent updates to all the doctors so that it benefits everyone as well. So for the cancer cervix, we had a competition, sir, a slogan and a poster competition that we had conducted, and we have the results as well, sir. So we would like you to kindly, like Monica will declare it, and we would like to you to kindly felicitate the winners for the same as well, sir. Thank you so much, sir, for being here. Monica, please go ahead.
Ashish, can you please share the PPT of the results slide, sir? So we are very happy to announce that we had more than 50 entries for slogan, and we had more than 20 entries for the poster for cervical cancer. For all of them were up to the mark and much more than that. And we have 2 kind judges who have accepted our invitation, Dr. Sharmila Madam, who has been the judge for the e-posters, and Dr. Alka Pandey Madam, who has been the judge for the slogan competition. They have been having a tough time to judge.
Can you please make it full screen and go to the next slide as well? Thank you.
They had a tough time to select which one was better, but nonetheless, somebody in the competition loses and somebody wins. Can you make it a full slide? We first would like to congratulate each and every person who has participated and made this a big drive. We would now request the prize distribution for the slogan competition first. The third prize Let's have the slide. This is Dr. Shubhra Singh. Her slogan was Garbhashay Cancer Se Mukti, Vaccine Se Yukti. This was the third prize winner. The second one is Dr. Anita Gautam Madam from Kanpur. The third one, the first prize winner for the slogan is Jagrukta Se Shakti Se Cancer Se Mukti from Dr. Taruchaya Madam from Jaipur. Congratulations to all the winners. Now we have the poster competition winners. The third prize is Dr. Archana Pathak Madam from Ranchi. Her poster was depicting almost all the epidemiology of CA cervix with the strategies of improvement of prevention and treatment. The second prize is Dr. Ananya Kaushik Ma'am, Jodhpur. Her poster also was a self-explanatory one, and the first prize was earned by Dr. Palak Bansal from Bhopal. Thank you, and we congratulate all the winners, and we request all the FOGSI members to keep on participating in all the initiatives that Public Awareness Committee takes. Thank you.
Sir, can we request you to say a few words of congratulations to the winners?
Yeah, I think they are wonderful posters, very beautifully made, and they really deserve the prize. But now we must also remember that somehow we must find a way to use these posters. How are we going to use them for awareness in the public? So, Priyankur, give it a thought, find out how we can do it.
Sure,
and then secondly, I forgot to tell you that we had a big competition of we had a World Cancer Day, and we did nearly 60 societies participated in doing a lot of cancer screening. It was a fantastic, and there were 9 societies that's on the ground. They really participated, and they did a fantastic amount of work. That is also very important. So what we need to do is always translate whatever we do into action. That is very important. Ultimately, means I am an implementation person. I am not just, I believe in implementation and action out of it. So what is the actionable point? How are you going to use these posters to implement them in public? That is very important. And I'm sure that Priyankur will find, and his team will find the answer to that. So thank you very much. And congratulations again to all the winners. Priyankur, are we giving them any prizes or not?
Yeah, we'll be sending them the certificates, which will be sent to them at home, sir.
Okay.
The Corona Remedies team will be sending them to the home, sir. And as you said, sir, like for the Pratibandh event that we had the competition, sir, especially the TNFOG team, which was led by Revati Madam and Sampath Kumari Madam, and they did the maximum number of events with the Madurai team, which did a mega event.
9 of them, we had classified into A, B, and C societies. So in each of the classification, 3 societies won the prizes. So we'll be now we'll be also communicating through the email to all our members who won the prizes. See, that is very important. The end point is very important to implement. So that I will be communicating and so that they are also happy that their names and people are aware which are the societies that did a lot of work and won the prizes. So that is also very important. To give ownership of the success to that society is very important. Thank you.
Thank you so much, sir. You always believe in inclusiveness, sir. And again, as you said, the winners will definitely include them. Maybe in the next program, the flyer that we make, we could use that as the backdrop.
No, I think that what Priyankur, I suggest that next program, maybe you can get those winners to participate in your next program.
Perfect, sir. We'll do that, sir. As you say. Sure, sir. Thank you so much, sir. Thank you for being there with us.
Thank you so much, sir. Wishing you a very happy birthday once again. Thank you so much for joining us.
Thank you very much.
Thank you, sir.
At the back, she's having the happy birthday and balloons.
Bye.
Enjoy.
Thank you.
Bye, sir.
Thank you so much, sir. So we'll go ahead with the scientific program. We request Ma'am Raghavendra Prasad sir and Rekha Rajendra Kumar ma'am to kindly continue with the panel discussion. Thank you so much.
Do you permit me to share the screen, Priyankur?
Please go ahead, ma'am. Thank you so much.
Yeah. Yeah, is it visible?
Yes, ma'am. Yes, it is.
Okay, fine. Yeah. This all we have finished. Yeah. Now I will ask Dr. Sushma. We are going ahead with this panel with Dr. Raghavendra Prasad and expert comments from Dr. Shobha Gudi, who has been the family planning committee, that is a FOGSI committee chairperson all this while. Welcome, Dr. Shobha, and we are happy to take your inputs also as an expert, and you can interrupt us in between and make us wiser. Now to Dr. Sushma. Dr. Sushma, what are the different benefits of family planning and contraception? Why do we promote it so much? If Dr. Sushma is not there,
ma'am. Yeah, I'm there, ma'am. So the main benefit is, ma'am, to prevent the unwanted pregnancies and also unsafe abortions, and to reduce the maternal mortality and morbidity, and even the infants' mortality also. That helps also for the economic growth of the country, ma'am.
Exactly. So we should not think only in terms of mother and the baby. It has got a much wider perspective. It's such an empowered tool for us, and these are all the advantages and benefits of family planning and contraception. Another thing I would like to add is it prevents the HIV and AIDS. Not all the contraceptives, but we know as we proceed along, we will talk about that also. Also, it reduces the adolescent pregnancies. So these are all the advantages of contraception. So these are again some slides. Let us move forward. What do you mean by the cafeteria approach, and what are the advantages of this? Dr. Indira, can I take words from you?
Yes. We are offering the right to the couple to choose the method, and that gives the confidence to the individual about contraception method. And they should feel comfortable in using the method they have chosen. So it's clear and accurate, and specific information is provided to them.
Yeah, counseling goes far way in this, so that we explain everything, they accept it. The main advantage of accepting is that the dropout rates will be much less, so they'll continue with the contraceptive. So let them select what they want, very much tailor-made according to their needs and according to their wishes, right, Dr. Indira?
Yes.
Okay, fine, thank you. So this is all in detail. Again, greet, ask them question, the couple, then tell them whatever they want, relevant information, help them in making choices, explain everything written. So what is together called as gather. So it's a greet, ask, tell, help, explain, written. So part of counseling, so that the cafeteria approach becomes more powerful and gets accepted from the couple. Okay, now the next question would be, what are the different methods of contraception? We are going a bit fast because we have more questions and less time. Okay. Yeah. Dr. Omna, madam.
Now, madam, we have the temporary methods of contraception as well as the permanent methods of contraception. For the temporary methods, yes, we can go for barrier methods, natural contraceptive measures, intrauterine devices, oral steroidal contraceptives. And for the permanent methods, we can go for male and female sterilization.
Yeah, you are very much right.
Occlusion, vasectomy, and for the female, yes, ma'am.
Yeah, so these are again in detail, like the hormonal emergency contraception, all this we will talk as we proceed. Okay. So yes, these are again in detail, like how to make the method more effective so that they accept. This is all in details. Okay, now coming to this slide, estimated number of women of reproductive age, that is 15 to 49. So look at the blue one, that's a dark blue, that is go for the modern methods, and traditional method is that light blue one, that percentage is only 4%, and the unmet need, that is also a big one, and there is no need in around 42%. This is what we want to say is using modern and traditional contraceptive methods having an unmet need for family planning and no need for family planning. Word with is just the statistics, so make it clear and make it bit easier. So now coming to the next question to Dr. Sangeeta Menon. We are talking the very primitive method now, that is the barrier methods. What are the different barrier methods? You can explain about male as well as the female barrier methods, Dr. Sangeeta.
Yeah, yes, the male condom and the female condom largely. The male condom, we know it's been in use for a long time. But I think I would like to draw attention to the fact that it is not really so old and traditional. I think it's very important that we promote the use of the condom, especially in the days when you have sexually transmitted diseases. And where the HIV is concerned, we use what is called the double Dutch method. That is, you can't use just the condom because it has, as you rightly said, it is old, it is not so fashionable, but because it has a large failure rate. It's up to 25% or more than 5 per 100 woman years. But still, it is the only thing that can prevent sexually transmitted diseases. So in the adolescent population, I think we should be really going strong on the male condom. And at the same time, looking at another method to back it up, like the oral contraceptive. That's why it's called the double Dutch method, especially in HIV positive, whether they are congruous couples or incongruous couples, you need to use the double Dutch. That's the male condom. In addition to preventing sexually transmitted diseases, it has a lot of other, the male is in charge, he has more. However, slippage, breakage, all this is there, whereas you have the emergency contraceptive to tackle that. The female condom, the Fem Shield, has come into play in the last few years, but not so widely used, probably because it is not being supplied to the government free of cost. It is a bit expensive. Very many women are uncomfortable with using this because they have to insert it on their own. It has two kinds of rings, one that fits inside and one that fits outside. And intercourse actually takes place through but not very much in use. I think the cervical cap, the mask, the diaphragm is largely, I think it's there as museum pieces in our teaching institutes. It's hardly ever used. But I would still be a propagator for the condom because the worry of STIs, and especially in the adolescent age group, I think we should be looking at it strongly.
Yeah. When we talk in terms of probably the Raymond Pearl index, the effectiveness may be slightly lower compared to our modern kind
Dr. Rekha, there are two. It is the there are two kinds of use. Is the actual use. This is what they, they don't do it properly. Or the projected use, which is how the failure rate per 100 women years, the Pearl index is extremely low when you have a proper use, but when the projected use, which they use just, probably not using it at the right time, there's a lot of prosthetic secretions that goes in before, yes, the failure rate is high, slippage, everything is an issue. I think this needs, your adolescent health work should include this as part of their teaching module.
Yes, exactly. So in spite of all that, though it is bit lower, the effectiveness of this, another advantage that is the prevention of the STIs. That is the greatest advantage of the barrier methods. Now, what is the mechanism of the barrier method? Like, how does it act? To Dr. Rehana, if she has come there. If Dr. Rehana is not there, the question will go to Dr.
Ma'am, Dr. Deepashri madam has joined, ma'am.
Yeah, that's what. If Rehana is not there, I will ask the question to Dr. Deepashri.
Yes, ma'am. Hello.
Yes.
Yeah. Barrier methods prevents the entry of sperm into uterus during intercourse.
Yes. Fast.
They have higher failure rate. That's all, ma'am. They prevent the sperm entering into the uterus.
Yeah. Okay, fine. Thank you. It prevents the entry of the sperm into the uterus during intercourse as a main mechanical and the chemical part also, because they have all the different kind of chemicals in the sponges and spermicides, etc. Dr. Joylene is there? Dr. Joylene? Okay, fine. Now, all right. Now I will ask Dr. Radha. Dr. Radha is there? Okay, Dr. Sushma.
Newer barrier methods, ma'am. There is a newer ring which has come.
Who is speaking?
Yeah, ma'am, Dr. Sushma.
Okay, Dr. Sushma, please ask
new
this question.
Barrier method. Yes, ma'am. New barrier methods, so like a female barrier methods, ma'am, like a newer ring. So that can be inserted once in a month, and it is very easy to insert where a healthcare provider is not required. And also it doesn't require any spermicide, and also makes the periods more regular and less painful.
Yeah, so that
and
is
more effective also, ma'am, almost 99% effective.
Yeah, it releases a low dose of progestin and also estrogen, and it's like a controlled release fashion of these hormones. That is the better. It is not just the barrier; it has the hormonal advantage also. So it is more effective that way. Okay. Now, what is the mechanism of action of
Rekha, am I
yes.
audible? Rekha?
Yes, you are very much audible.
I'm traveling, that's why I'm checking.
Yeah.
Just wanted to say that if your ring is only in the ring form, then it is not a barrier. It is
Not
just
a
a ring.
barrier.
It's a combined hormonal contraceptive, and that is one. Actually, it was appreciated very much by women, and it was there in the market for a good 5 to 6 years. We don't know why exactly. It has not been there for some time. But actually, we all, when we were working in this committee, we felt that if it comes back again, it is really a boon for the gynecologists and the clients, because women do accept it and they are comfortable with it. That's one thing. Just one brief point I want to make about barriers. Everybody has spoken very well on that. Only one thing we need to remember is there is only one type of condom which has been FDA approved for prevention of HIV. All other STIs may be,
Shobha, there is some disturbance since you are traveling. Hello, others can hear her or only myself?
No, it's not audible.
No, by both male and female condoms. There is only one. Even the government of India says only the male latex condom.
I think what Madam was getting at is that the male condom is the one that's more beneficial for prevention of HIV, but not the female condom. It's not yet approved for prevention of HIV. Madam, Goody Madam has said to please carry on.
Yeah, exactly, Sangeeta. Yeah, exactly.
Yeah. Since you're traveling, there is some disturbance or breakage of voice. So that is why Dr. Sangeeta summed up what you said. Is that exactly what you want to say or anything else you want to add, Dr. Shobha?
No, carry on. At this point, carry on, please.
Fine. Okay. Yeah, please give us some input wherever we need so. Okay, I will proceed then. Okay, now what is the mechanism of action of IUCD to the next panelist, Dr. Indira?
It causes chemical and cellular changes in the endometrium. And this copper on this IUD, it alters the uterine and the tubal fluid. That is, it hinders the spermatozoa motility. And thus it will prevent implantation.
Yeah, the endometrium also becomes very hostile for the embryo to sit there. And whatever you have mentioned, agreed. We are not going into details of everything, Dr. Shobha. Since we have only 45 minutes, we are touching upon the important superficial and practical points. Okay. Are there any different types of IUCDs depending on their content? Like, are they just mechanical or they're hormone laden? How is it? Can Dr. Omna Madam explain on this issue? Dr. Omna? Hello? Dr. Sangeeta?
Yeah, so actually you look at the history of IUDs way back in many centuries ago, they used it for camels and things like that. When they crossed the desert, they put stones inside the camel's uterus so that the camels wouldn't conceive and deliver on the way. I think the same philosophy exists. But those days,
body in the uterine cavity.
Yeah, the Lippes loop and the Safety, which is all really, they were inert devices. I think now we see them only in some old hysterectomy specimens. We don't really see them at all. But yes, the copper releasing IUD is really good. The copper T380A, where the A stands for the arms and the copper is there on the arm as well. Really good because it is one free, given by the government, very acceptable. But the only problem is that some women tend to experience a little bit of heavy bleeding. If they're counseled well, they will do well. And it's available and it's there for use for 10 years. So two such devices take care of her reproductive career.
Others, please mute yourself except the panelists and moderators. Please mute yourself. This is a request. Yeah, please
So
carry on. Dr.
other than the 380A, what we are seeing now is the LNG-IUS. It's a superb device, not just as a contraceptive, because if you're thinking cafeteria approach, I think that would be the way to go, because each woman's needs need a different kind of satisfaction. There would be a woman who has heavy periods and who has really not much endometrial pathology and who would benefit from using progesterone within her uterus, because the delivery into the uterus is very large. Even though it releases 20 micrograms per day, the delivery into the uterine endometrium is very good. So the what is it? The LNG-IUS is here to stay, not just as a contraceptive, but also as a means of preventing so many hysterectomies. And the copper-releasing IUDs, we must understand that on a global level or even on a national level, the Mirena is not being, or the LNG-IUS is not available free of cost, whereas the copper T380A is. So yes, it can be used. And now you have the new ones, the fibroplant, the gynae fixed arms are shorter. There's a this device. Haven't seen them as yet, but yes, they are coming in.
Yeah. Okay. And regarding the copper releasing IUCD, we also should counsel them that very beginning few periods may be bit more flow. Second thing, you may have premenstrual spotting also, which also disappears gradually as the use continues. Exactly. Yes. Let us talk elaborately on the hormone releasing IUCDs later on. Now, I will move on to the next question. How does the progesterone act in IUCD? Dr. Radha? I don't think she has joined. I think only 5 panelists are there. Okay. Dr. Deepashri, can I ask this question to you, Dr. Deepa?
Yes, ma'am. Yes, ma'am. The progesterone which is present in the IUCD basically imparts its actions because it mainly acts on the sperm motility, and thereby it impairs the sperm's motility and its sperm's function. It also inhibits the conception mainly by which causes fertilized ova not to recover, and it is important to note that it is not an abortifacient. Apart from these actions, even the progesterone will cause thinning of the cervical mucus, ma'am. And it also on the endometrium, it has its action and causes atrophy of the endometrium, which is the main cause for AUBs. And it also impairs the tubal motility. With all these multifactorial actions, the progesterone which is present in these IUDs has beneficial effect not only as in contraception, but also on a patient with AUB.
Yeah, this atrophy of endometrium is a very helpful advantage of these progesterone IUCDs, where, as Dr. Sangeeta said, many of the uteruses have been saved. The endometrium goes to sleep in most of the cases. They go to amenorrhea after, say, probably 6 months of use or so. The uterus really sleeps with the use of these progesterone IUCDs.
Yes.
Fine. Now, please explain about the contraceptive content. Like, if you can.
Yes, I think it's been covered, madam, by Sangeeta. Always, Dr. Sangeeta spoke about LNG already, madam.
Yeah, but the little bit about that. But this just wanted to show this slide. That's all. The length and all that. I will skip on this slide, Dr. Raghavendra. Yeah. Okay. What are the non-contraceptive benefits of LNG-IUC? Is the AUB treatment. Other than that, it also helps in other cases, pathologies like endometriosis, adenomyosis, PMS, and other medical management of fibroids, and also used as a progesterogenic component in case of HRT. Like the progesterone component of the HRT is from this LNG-IUCD. So the newer LNG-IUS, that is intrauterine systems. Can Dr. Sushma tell us on this some more details? Can you throw some light on this newer LNG-IUS intrauterine system, Dr. Sushma?
Yeah, ma'am. So there are newer LNG-IUS like fibroplant, like they are frameless, and also they can release 14 microgram per day and also 20 microgram. There are 2 strengths, and as Mirena, they are also useful for up to 5 years. And most important is they are suitable for all type of the uterine sizes and the shape. Sometimes uterine fibroid, like multiple fibroids, like where previous LNG-IUS was not suitable, because now these are frameless, they can be fitted well in the uterine cavity. That is the main advantage of the newer LNG-IUS.
Yeah, like if there is a cavity abnormality, like the fusion abnormalities of the uterus, or like the submucous myoma, also these can adapt themselves inside the uterine cavity, isn't it?
Yes.
Yeah. Okay. What are the advantages of LNG IUS? This we have already explained everything. Lactating mothers can use. That is another advantage. Immediately reversible and is ideal for spacing. This we have spoken already. Any disadvantages of LNG IUS, Dr. Indira, madam?
Yeah, at times the insertion of the device might be painful. Some women might have menstrual irregularities. A trained person is definitely required to insert this device, and there is no protection against sexual transmitted diseases. And at times they can have pelvic inflammatory diseases, and women cannot stop using IUD on their own. They have to visit a doctor for removal. And at times there might be risk of expulsion of also.
Yes, in a multi-parous uterus where the cervical os is bit patulous, there is a risk of expulsion in these women. Dr. Raghavendra, you want to give any input here? Dr. Shobha, Dr. Raghavendra?
No, madam, let's carry on.
Okay, fine.
Okay.
So these are some complications, not much to worry about. There are small and not so important kind of complication. All of us know about this, rarely uterine perforation while inserting vasovagal attack, dysmenorrhea, etc., etc. Not to forget to check the threads so that the misplaced IUCD we should detect at the earliest, especially the uterine perforation. Sometimes it can be a thread, may not be seen, but may be very much inside the uterine cavity, which we make out by some investigative modes like transvaginal scan. But sometimes it might have really gone out of the uterus somewhere up and above. How does the birth control pill work? Now we have finished the IUCDs, that is intrauterine devices, and now come to the birth control pills. Dr. Omna, madam. Omna, madam.
Dr. Traveling.
Yes, ma'am. The OC pill basically has its action on the ovaries and the endometrium and also on the cervix at a different level. At the ovary, it acts and stops and prevents the ovulation. In the endometrium, it causes thinning of the endometrial lining. And in the cervix, it causes thickening of the cervical mucus, making the entry of the spermatozoa hostile to the fertilization. So it has basically all these three combined effect, which causes prevention of the pregnancy.
Yeah, that is why it is very efficient, and we give the success rate up to 99 and 0.9%, because it acts at the very origin itself. It stops the ovulation itself, isn't it?
Even if one factor is not acting, the other two anatomical factors also can take over.
Yeah, that's why we say it's a 99% effective. But as you said, the only disadvantage is, unlike the barrier contraceptives, there is no protection on STDs. Now coming to the controlled ovarian combined
OC pills.
Yes, pills. What are the different types? Combined ovarian
basically they are classified into 4 generations, starting from the first generation is the earliest one, first, second, third, and fourth. The latest generation is the 4th generation, ma'am.
Yes.
So most commonly used drug is the Dynogest. So nowadays, first generation combined OC pills is norethisterone. We still use it for prevention of postponement of pregnancies.
Yes.
And also for controlling bleeding in a AUB case, ma'am.
Treatment of
AUB. In second generation, we have a newer drug called as levonorgestrel. That is what we are using it in Marina. That is LNG IUS. And in third generation, the classical drug is desogestrel, and the fourth one most commonly used is drospirenone in PCOS, and Dynogest, which is most commonly used in endometriosis. So apart from these uses, all the generations of these progesterone contents can be used for contraceptive benefits also.
Yes. So these are the 4 generations of combined OCs. We also should not forget about the progesterone only pills, where they have their own rules, like the lactating women, etc., or the women who cannot take the estrogen part, like the aged or who have the thrombotic episodes previously, etc. Those kind of women where we cannot take the estrogen part, we have to advocate only the progesterone only pills. Okay. Now, what are the benefits of OCPs? Dr. Sushma, benefits of oral contraceptive pills?
So as we are discussing now, we know that the main benefit of the OC pills is from the birth control, that is contraception. But apart from that, it has got many advantages like prevention or the control of the ovarian cyst. And also when used for a long time, it can even prevent the ovarian and uterine cancers. And also like a dysmenorrhea when associated with adenomyosis and endometriosis. Most of the time in adolescents for the regularization of the periods and for the prevention and as a treatment for acne also, ma'am.
Yeah, we also use in the to decrease the incidence of ovarian cysts, especially in case of our infertility practice, where when we check on day 2, we want all the follicles to be on the same page. We don't want one follicle having a cyst or a bigger follicle. So it's used as a pre-treatment also in infertility treatment before you start the proper infertility treatment initiation, isn't it?
Yes.
Yeah. Now, what are the side effects of birth control pills, Dr. Indira?
The common side effects are some women experience breast tenderness, some have nausea, headache, mood changes might be there, and weight gain changes will be there.
Huh. Yeah, okay, fine. Can Dr. Indira tell me that how to take the pills? Like we know that it has to be taken one at bedtime, start on the first day of the period, maximum second day, etc. But my question is like to be more clear to the patient, if they don't take one pill in between, how is it? If they don't take 2 pills successively, how is it? During the ovulation time, how is it, etc. I hope you understand what I mean.
Yes.
The further details about that.
Yeah. So if they have to take the pills on the same time every day, and if they miss a pill, they can take that pill on the next day whenever they remember it, along with the prescribed pill of that night. And if they miss more than 3 to 4 pills, then that cycle they have to be careful. Though they can continue the pills, they have to be careful of the ovulation. There might be chances of conceiving. Now, in case for sometimes we also counsel that we can use condoms for the first month to get used to the first pill pack they're using. And when they're on antibiotics, also the efficacy of the oral contraceptive pills might reduce. So condoms are usually advised. And if they miss a pill, the other option is you can use condoms during that week.
Yeah. Dr. Shobha, you want to add anything here? Dr. Shobha?
Dr.
Okay.
Rekha, can I say something?
Dr. Sangeeta, is it?
Yeah.
Please.
If to be effective for the month that you start, it's ideally started on either the day 2 or the day within the first 5 days of the period, and then you don't need to use a backup. But if you have missed a pill, if you've missed just one single pill, then it's okay. You take one at the time that you remember it, and the next one at the usual time. Once you've missed more than a pill, it's important to figure out whether you've missed it in the first part or the latter part. So then it is important to start using a condom for at least a week.
Yes.
And
can I add something? Some days it may be 2 pills together, one in the morning, one in the night, if she has missed the previous night one.
Absolutely.
Also, if it is more than 3-4 days continuously, we should warn her about the bleeding also. The breakthrough bleeding also should be explained to her.
And always, I think it's good to tell them to keep 2 pill packs, one at home, and if they're working, one in their bag. So if they've forgotten it, they take it at that same time, or to associate taking the pill with some activity like brushing your teeth just before going to sleep, so that things that you would do every day that you won't forget.
Keep on the pillow, etc., etc. Especially when they're traveling, they have to have 2 sets. Because changing the purse is more common in ladies all the time. We keep changing our purse, isn't it? Yeah. Coming to injectable, Dr. Raghavendra, you want to take over?
Okay, madam.
Yeah.
Yeah.
I'll show the slides. You please carry on.
Yeah. So let's have a discussion about injectable contraceptives. But before going to that, this is what the session will get when you have 2 IVF specialists talking about contraception. You will have more of theory and less of practical, because all our contraceptive use is only for regularizing the cycle or going for regularizing our batches of IVF.
That's why I've been asking Dr. Shobha in between.
So let's have the next slide, madam.
Yeah.
Yeah. So anybody in the panel, you know what are the types of injectable contraceptives? I've just mentioned it there. You have the progesterone only and the combined ones also. So can anybody in the panel just mention about how these are given and what is the mechanism of action of these particular shots?
Do you want me to take that, Raghavendra?
Yes, madam, please.
Yeah, so the DMPA can now, there is a intramuscular use and a subcutaneous use. It's 150 milligram depot medroxyprogesterone acetate given once in 3 months. It's fine. There's something called a grace period. That is, even if you forgot it in 3 months to take it, even though textbooks will tell you 2 weeks, you're okay. It's actually WHO says you're okay for a month, but you don't tell the patient that because you want her to come back correctly for her injections. And it's extremely effective. And since both of you are reproductive medicine guys, I would like to ask you, I'm very uncomfortable with the Depo-Provera when I expect fertility in the year or two ahead, because it sometimes makes the endometrium so very thin that it's extremely difficult to get that endometrium up and going after that. And they experience a lot of breakthrough bleeding. And it also tends to cause a little bit of bone damage. It takes a little bit of calcium off the bone. So either they must be really mobile and take supplemental calcium and do their weight training exercises. But it is extremely good, especially women who go into amenorrhea. It's good for them. But if she's expecting fertility in the near future, I think this may not be the ideal thing for them. I don't know what your take is on it. This is what is my experience. But yes, Depo-Provera is good. The subcutaneous route has the same kind of effect. The only, the mechanism of action is like any other progesterone. It just makes the cervical mucus thick, make the endometrium very thin. And even though you have estrogen in your system, the progesterone is so large that there are no estrogen progesterone changes. So you have a very unreceptive endometrium and pregnancy is prevented. The estrogen progesterone combinations, your Mesigna and Cyclophem, are not available in India today. So I'd rather not discuss it.
Yes, Dr. Sangeeta, I totally agree with you that Depo-Provera is a very good and efficient progesterone contraceptive. But one, in coming to the contraceptive point of view, there needs to be a lot of counseling in women, because in our Indian women, the mentality is if no periods is equal to pregnancy. Most of them, until and unless you counsel them so much, they keep coming back to you, especially if they have breakthrough bleeding, the visits are more. They keep coming and you can't do anything, unlike your OCP or your IUCD. Coming to the infertility practice, it is out of our basket. We never use Depo-Provera in infertility. It is never a drug in our practice. We do use sometimes GnRH agonists for the suppression, that is down regulation, etc. But Depo-Provera is not in the infertility basket. Even
Rekha, what I meant was that if a woman is expecting to conceive in the next 8 months, or she wants something for 6 months or 1 year, this may not be the thing for her, because her endometrium, not for infertility practice, but for women who expect fertility in a year, this may not be a good thing.
Yeah, even then.
Sangeeta, am I audible, Sangeeta?
Yeah, sure.
Am I audible?
Yes, you are.
Audible?
Yes,
yeah.
yes.
So I wanted to come in here. Now we are talking about women who desire contraception, who desire spacing between pregnancy, and Depo-Provera is a very efficient contraceptive. So what we must do now is clear our minds against any barrier towards prescribing this. Depo-Provera is entirely reversible in its contraceptive effect. I think what Sangeeta meant to say was that if the woman wants to conceive in a year, so what I'm trying to say here is it's very effective for post-abortal, post-MTP or postpartum, because this is a period where a woman doesn't want pregnancy for some time. And if a woman wants spacing for 3 years, then we can give her, injectables for the first 18 months or so and stop. Yeah. So that by the time she regains her fertility, her desired spacing has been achieved. In fact, even in Government of India, when Antara has become so popular, they also feel that use this contraception on women for 18 months. Encourage them to come for those first 6 injections or so, every 3 months, so that a period of 1 or 2 years, 1.5 to 2 years is covered, and that's enough. After that, we tell them not to come back for contraception, and we tell them that the fertility will return after 6 months, and that serves the purpose. So return of contraception is not a problem, or fertility is not a problem, if we fine tune our duration of prescription. That is one thing. The second thing which Sangeeta wanted to say was about bone loss. Yes, there is bone loss, but it is transient, and it can be limited by effective lifestyle with exercise and calcium, and dietary calcium. And thirdly, it is entirely reversible. It is entirely reversible. So I think the barrier in the provider's mind must go, that it is, and it should be an effect. So whatever you have been discussing now, every method deserves to be in the basket of choice, because the woman may not like the pill. She may prefer the injection. So we should be able to offer that to her with conviction. That's what I wanted to say. Thank you.
Yeah, agreed, Dr. Shobha. I totally agree with you. What I was telling is, you are talking about the person who wants pregnancy after some time. But since Dr. Sangeeta addressed the infertility specialists like us, we just put our input and opinion as as infertility perspective. That's all.
Yeah. Shall we move ahead, madam? Let's go to the implant part of it, because right now, I think all this was discussed, madam. We'll move to the implants. The main thing right now is, when you look at implants, that's the latest thing which is coming now, where I think a few of them have been given training for how to use the implant. So what is it? What is an implant? Please enlighten us on what is an implant, what are the types of implants available, and how does it work? Anybody? Dr. Indira?
Yeah, I have no personal experience of implants, but I can only tell you theory. So it is placed in the body with hormones filled in it. And it is, they say it's a simple procedure of 15 minutes, an OPD procedure. And they are plastic-like capsules, which are inserted under the skin in the arm. And the effective rate is very high, 99%. The types, implants mentioned are Norplant, then Implanon, Nestron, and Uniplant. Are they all available here?
Actually, we were part of an ICMR project for this, and the women accepted it beautifully. It was easy to insert. We were with the Norplant. It was really very well accepted, but it's not easily available. No.
So it's mainly a theoretical discussion then, because even during our exam, we used to buy out Implanon, and keep adding on the dosage and everything.
Correct.
So even now, I think it is still theoretical only then. So Dr. Indra, I think you can continue with the theory part of it then.
Yeah, so Norplant 1 has 6 capsules, and it is used for about 5 years. And Norplant 2 has 2 capsules, and it is used for 3 years. It's same, the action is same like combined estrogen progesterone pills. And it is advantage is the long-term control pill, and effectiveness is good.
Can I speak here? Can I speak, Raghavendra Rao? Can I speak?
Yes, madam.
Yeah, sorry to interrupt, but I must disagree with the previous speaker who said that the efficacy is the same as combined estrogen progesterone. No, implants are progesterone only methods, and they are available in the market for the client. Only thing is, the provider has to be trained. So it's possible that when we write a prescription, it is possible to get this only if the provider is trained in insertion. So the organon company is keeping a track of who all are trained, and they are providing the devices. So not to worry, it is going to come in the government basket also very soon. And what is available now is not the Norplant, it is the Implanon NXT, which contains etonorgestrone, 68 milligrams of etonorgestrone, synthetic progesterone.
Okay, Dr. Raghavendra.
Yeah. Okay. So then we'll move on to the next permanent methods of contraception.
Okay.
Dr. Do you have Dr.
Sangeeta,
Rahana
Dr.
here?
Radha, Dr.
Yes,
Oma,
sir.
Dr. Indra.
Yes, sir.
Yeah. So, yeah, can you just enlighten us? What is the when a patient comes to you for a permanent sterilization, or what is the method you prefer to do, or when would you do it, preferably?
Puerperal or post-abortal or interval, sir. 3 types. Immediately
And which
after the
particular procedure would you prefer? Which type of sterilization would you prefer to do?
Polymerized method, sir.
Okay, yeah, I think most of us, I think I will be doing either the Pomeroy or the Parkland. Rest
Polymerized method,
yeah,
sir.
rest everything I think is for theoretical textbook
Yes,
or
sir.
PG discussion.
Yes,
And
sir.
when we go for interval sterilization, we go for laparoscopic.
Yes, sir.
Yeah.
Yes, ma'am.
Ma'am, can I
So
add one point?
Yeah,
Yes,
please.
yes.
Actually, whenever the concept of contraception comes, even the methods, everything is directed only towards the female part. So I would like to emphasize here, at least when it comes to the permanent contraceptive measures or permanent sterilization, the male counterpart also has to be given equally.
Yeah. Next
Because
slide
it's
is
not
on
only
that only.
Yeah,
Next
Yeah,
slide
we
is
are
on
coming
that.
there. We are coming there. We are coming there. We are
I had
reaching
seen
there.
that slide also, actually.
Yeah. So please, doctor, tell us about what you want to talk about the male sterilization part of it.
Yeah.
No, actually, because this is a neglected part, not only by the patients, even for the doctors, because females are our patients. Usually the male attenders or the husbands stand outside the OPD. Unless we call them, they don't come in. So we also fail in our part to counsel the male counterpart for the permanent sterilization. And the patient would have undergone 2 cesareans. So I think a non-scalpel vasectomy, which is a non-invasive method, can be the best choice for a girl, for a lady who has already undergone 2 operations of cesareans. So equal emphasis should be given for a male counterpart to actively participate in the sterilization part. The onus should also be given to the male part. That's it.
Yeah, that is true. Yeah, that we also should.
But practically, I don't think it is possible, even with the best of the education. I don't think the acceptability is that well accepted by the
I've
male.
also noticed that the wives are reluctant to let their husbands under the knife. That is also one point. So even though we counsel so much, they are not. They don't allow their husbands to go through it, for whatever reason.
Yeah.
Anyway, let's. Yeah. So the rest of it, the other one, what you're seeing on the screen is only purely for theoretical, because I don't think anything of this sorts are available in our country. So in case that there are anybody who is postgraduates who are there, it was for them. Now let's go look at some of a few scenarios. I'm 19. I'm sexually active. I'm not married. What do I use?
OC pills.
OC pills are better.
OC pills.
So I think generally over the panel, the discussion will be still on OCPs only, preferably OCPs, nothing else.
Encourage
She's
the
not
male
married.
partner to use the condom as well.
Exactly.
She has,
Yeah, that is.
she has a pouting endocervix on the ectocervix. Her transformation zone is going to be exposed to HPV, early coitarchy. That's one worry. Sexually transmitted diseases is the other worry. I would think a double Dutch method. Let her use the contraceptive, which is the oral contraceptive, which is in her armamentarium, but encourage the use of the male condom.
I will send you by mail or WhatsApp.
Pardon?
Okay, thank you.
Okay, so this is basically what we were looking at. Can I have the next slide, madam? Yeah, I need a break. I need a gap. I am fed up right now. What do I do? It's
So
open for all the panels.
IUCD, sir.
IUCD, sir.
Anything else?
After 6 weeks of delivery,
Injectables
even
also.
the injectable
Injectables
contraceptive.
also will work well.
Okay, and IUCDs, how would you prefer? When would you prefer to use the IUCD? Immediately, I mean, during your
No,
cesarean,
after
immediately put off?
Yeah, PP-IU series which are coming up, sir, now. So if the patient is acceptable, that is a good time. Otherwise, injectables will be better. during
Do
the
you
now
prefer
lactation.
she's
her for
asking.
oral medications anytime, planning any oral medications?
Yeah, because she's lactating.
POCs, if you have estrogen, reduces breast milk output by 40%. So it's a definite no if she's lactating. But yes, the progesterone only pill, if she's a highly motivated woman, fine. The grace period is only 3 hours. She has to take it at the same time every day. If she's okay with it, the POP is fine.
Okay. Yeah. Then the next one, madam. Oh shit. Something happened. What will I do?
Emergency contraception.
Yeah. So what would you do? How would you agree for, I mean, how would you counsel your patient for that?
Duration of the exposure, sir. 72 hours, within 72 hours or after 72 hours, did the patient come to us?
They're still on the bed, so it is immediate. Yeah. So
We give
can you,
3 tablets
yeah,
of overall L, and after 12 hours,
and
another 3 tablets of overall L, sir.
is it the same opinion with
It's a
everybody?
good alternative.
I feel.
Levonorgestrel single shot 1.5 or 0.75 within 12 hours apart, 2 doses, either one is the best alternative. When you give so much of estrogen, some of the time she vomits. Yeah, that is the ASPI regime which was done. You took a double dose of the standard COC, but with so much of estrogen, very many of them vomit, and it's uncomfortable. When you have the single shot 0.75, I think that would be the best.
What about the emergency copper T insertion?
That's if she comes within after 72 hours and within 5 days, that's perfect. And it should be a copper containing device, not your LNG IUS.
Yes, copper T. That's what I said.
Okay. So shall we go for the next slide? Yeah. So what can she use? She's an obese lady, quite obese. So what would you prefer her to use?
Copper T, sir. Copper
I think
release.
is that, yeah, is it the same thing for all the panelists? The opinion is the same?
I think we should start getting into the medical eligibility criteria set forth by the WHO, and where obesity is a concern, where estrogen is concerned. And I think we should discuss these kind of things with the patient and tell her, is she in the A, B, C or D category? And even the low dose estrogen containing pill is okay if she doesn't have a previous history of venous thrombosis or no strong family history. That would be a category B.
Yeah, I think Sangeeta is right that instead of, am I audible?
Yes, you are, Shobha madam.
Yeah. So I think she is right that we must offer her a choice, because she is an obese person. We cannot say that she doesn't have a choice. We cannot say that only this method is suitable for you. Let us not forget that there are non-hormonal contraceptives also, which are pills, and that is centroman, and that is also has been a very successful contraceptive method in the public sector, and there is no reason why we cannot offer that to her. Then the other one is that progestin only methods are actually safe for obese women, so that can be done. And low dose oral contraceptive pills also have a role, provided there are no other cardiovascular risk factors for her. What she needs to understand that there should be a strong parallel effort to optimize her BMI, which should be ongoing. So as long as they are on a reducing weight mode and on a lifestyle, modification, etc., I think even low dose combined oral contraceptives are assigned category 2 for them for short term use with regular revisit for the decision. So what is essential here is that she should get to choose, and she should not be told that there is only one method. So please make a basket of choice for her. And Sangeeta rightly said that it is going to depend on the medical eligibility criteria, which actually is very useful. And there is an app also for that now. So it is possible that you can download the app, and even the client can download the app, but you can also take her through the specific counseling purpose. Yeah.
Dr. Shobha, will the progesterone LNG IUCD will have advantage over the regular simple copper T in this case, even if he does not have the AUB part, thinking that the obesity and the estrogen side effects in her?
No, Rekha, I don't think that
Okay.
you can use this as prevention for endometrial hyperplasia. I think we all understand that there is no prevention in terms of local progestin for endometrial hyperplasia. I think she should get into the, reducing weight mode. I think her metabolic derangements, if she has towards hyperestrogenism, will be related to her weight. And there is no way that we can, counter that with an LNG IUS. So there is no saying that the LNG IUS is preferable to copper IUD. But yes, if she chooses LNG IUS, then she can be offered that. Yeah, she has to choose it. Yeah, there is no specific advantage, Rekha. Though I would like to say that there is. I would like to say that it is possible to protect her from endometrium, but it is not possible. Yeah.
Just wanted to give a clear message to panelists and all the audience. That's it.
Yeah, madam, since we're running short of the time, can we have the final slide? I am over 35. I am a diabetic, hypertensive. I've got 3 kids. What do I do?
Permanent sterilization, sir.
Yeah.
And if she doesn't want permanent sterilization?
I think the husband should undergo vasectomy.
Yes, because she is a high risk for everything.
Yeah, that is the reason. That is what I was trying to draw at. Yeah.
They want the 4th child.
No, the main point I would put the slide was just to highlight the point of vasectomy there. Anyway, it was nice having all of you here, Dr. Rekha ma'am and me. We have thoroughly enjoyed 2 infertility specialists drilling the panelists on a topic which we are not at all aware of on contraception. Anyway,
I like that.
So I would like to thank Priyankur and Dr. Monica, everybody for giving us this chance to enlighten ourselves on the topic of contraception. That's why it was more of theory and less of practicals. And anyway, thank you so much. Rekha, over to you, Rekha ma'am, to give us a final thank you.
Yeah, as Dr. Raghavendra Prasad said, I endorse his view. Thanks once again, because through this compulsory situation, we got ourselves to understand more about the contraception, what we probably had forgotten, and the nuances of the contraception we had to read again, and thoroughly enjoyed getting into this. Thank you, one and all. Probably the panelists knew much better than us. We don't know about that, but it was a nice interaction, and thank you all. Thank you, Dr. Shobha, for your great inputs. Thank you, Dr. Priyankur, for the opportunity. Thank you, Dr. Monica.
Thank you, Rekha. Thank you, Raghavendra. Thank you, both of you.
Thank you, ma'am.
Thank you. I stopped sharing here.
Thank you, ma'am. It was a very descriptive session. Each of us have had a take home message from this panel. We now move forward to the session which is more interesting. In case of failure of contraception, we need an MPP, and the government of India has come out with the latest amendment. Let us now make ourselves aware of the latest amendments in the Act, in GP Act. Let us introduce our chairpersons for the session today. Dr. Sharmila Madam and Dr. Vidya Topilare. Can we have the slides, please? Dr. Sharmila Madam. Yes. Hello, sir.
Monica?
Yes, sir.
I need to leave at 7, Monica, because I thought my talk will get over after the panel.
Monica will take Jadid's talk now, and then we'll go on to the next panel.
Yeah, that was the flow, no?
Yeah.
Ma'am, I'm asking Dr. Sharmila Madam to introduce her on here. Hello?
And please mute the people who are disturbing the.
Yeah, so much disturbance in listening.
Yeah, exactly.
Please put Sharmila Madam.
Please mute everyone first.
I will introduce Charmila and Charmila will introduce me.
No, ma'am, just give us a second. Monica, please go on. Monica, you're on mute. Please introduce the chairpersons.
I take pride in introducing Dr. Chamila Madam as a chairperson for this session. Madam is currently the Vice President elect for the next she is the governing body member of the ICAG Council. Ma'am has been a very active participant and an advisor in the public awareness committees. We welcome you, ma'am. The other chairperson for today's session is Dr. Vidya Thubi Madam. She is currently the president-elect of the association. Ma'am has many accolades and has been a national and international faculty. We welcome both of you, ma'am, to chair this session.
Thank you, Monica, so much. May I request Corona Remedies, a tech support, to mute everybody other than the speaker, please.
Yes.
Thank you so much for that. It's my honor to introduce Dr. Jaideep Tank. He's the President-elect of FOGSI 2024. He's been the Secretary General of FOGSI in 2018 to 21. He's a project lead of FOGSI.
I'm sorry to interrupt. Vashish, can we have Jaideep sir CV slide, please? Play it. Thank you. Sharmila ma'am, you can go on, please. Thank you so much.
And please mute that person who's interrupting.
Please mute. Otherwise, it is very difficult for us also to listen.
And it's one of the best talks. Please.
One of the best talks.
So he's a project lead for FOGSI USAID projects of 2020 to 24. He's a past president of the Mumbai Society. He is the Deputy Secretary General of AOFOG. He's the immediate past chair of FIGO committee. He's been awarded the FRCOG in 2020. He's contributed greatly to the electronic membership management system and e-voting for FOGSI, has contributed to several FOGSI statements, and is responsible for restructuring of the FOGSI cells. The minutes of the FOGSI MCM and GBMs have been streamlined by him. He has already drafted a proposal for FIGO for a 10-country project and is the technical lead for the project. He's now working on developing a project for MOGS, which is geared towards assisting underprivileged women in urban slums with the menstrual hygiene needs. A person who's an academician, a social worker, advocacy person. It's a great honor to listen to you, Dr. Jaideep Tank, on his talk on amendments in the MTP Act.
Thank you, Charmila ma'am. Thank you, Vidya ma'am, for chairing the session, and thank you, Jaideep sir, for agreeing to talk on this topic. You always mesmerize with this topic, and there's so much new to learn on this topic every time you talk this topic. But there's every time a new point that comes out, and we really love learning from you, sir. Thank you so much for being here, sir.
Thank you. Thank you very much, Priyankur. Thank you very much, Charmila, for that extremely kind introduction. I'm sorry, I will have to sort of cut short the talk a little because I'm in Delhi. I'm scheduled to go for another meeting here with a foundation in around 20 minutes. But let me first begin by congratulating and acknowledging Dr. Rishikesh Pai, the President of FOGSI, Dr. Madhuri Patel, the Secretary General, Dr. Alka, the Vice President, and I understand Dr. Sampath Kumari is also here. And of course, Priyankur. Priyankur has been of great help, I think, to just about everybody in FOGSI. And I call him the national coordinator because whatever seems to be happening in the nation, Priyankur seems to be coordinating it. Well done, Priyankur. We are looking forward to great things from you. I must also acknowledge the past chair of the committee who has done excellent work, Dr. Kalyan Barmade, and the coordinators and conveners of this program, Dr. Monica, Dr. Day, Dr. Bharti Rajshekhar, and Dr. Raghavendra Prasad. And congratulate both Rekha and Dr. Raghavendra for that very engaging panel discussion. I couldn't make out that you all were IVF specialists given the kind of discussion that took place. So congratulations on that. And of course, I'm delighted to be here and wish Rishikesh in person. I didn't meet him today. And of course, the wonderful guests of honor, Jayam ma'am and Dr. Sampath Kumari ma'am. And I'm so happy that Dr. Vidya Thubi, who had done such wonderful work, and I had the privilege of working with her, and Dr. Charmila chairing this session. Priyankur, you, as always, put together a brilliant faculty, and I'm sure that the next panel is going to be as engaging as the previous one. I'm going to speak on MTP Act and the recent amendments to the Act, and I find it useful to speak on this because I think despite the fact that the amendments have now been around for a while, there is still some confusion about it. So what I will try and do is just stick almost entirely to the part about the amendments. But before I begin speaking, I think it's important to establish some kind of a context as to why these amendments are important. And this context has to be in terms of both local, that means in context of the laws which surround abortion in India, as well as global. So let me begin by saying that I think gynecology, obstetrics and gynecology is probably the most regulated specialty in all of medicine. I practice in Mumbai in a nursing home, and I require something like 27 permissions and licenses every year to practice my profession. I don't think any other specialty in medicine is so regulated. In fact, I met a government official once and I told them that we should take it as a backhanded compliment because obstetricians and gynecologists are the most regulated specialty. And you obviously seem to think that delivering patients and doing ultrasound is more difficult than doing heart transplant, because actually heart transplant surgeons are fewer rules and regulations compared to obstetricians and gynecologists. And all these kind of regulations have actually led to a bit of a cynicism and skepticism amongst us who practice obstetrics and gynecology. It's like what Hermione says in one of my favorite book series. When Scrimgeour asks, are you planning to follow a career in magical law? And she says, no, I'm not. I'm actually hoping to do some good in the world, which is very ironic because I think it is crucial that we know and engage with all the policies and regulations which affect us. I'm not asking for a vote of hands, but just think to yourself, have you read the MTP Act fully, cover to cover? And if you haven't, I would strongly urge you to read it. For me, it is one of the most elegant pieces of legislature passed by the Indian Parliament. And it is particularly important for us because for us, it's an act which protects and empowers. And I'll tell you why I say that. So if you want to understand the MTP Act, you actually have to look at how the Act came into being, or what was the need for the Act, and hence the timeline. The MTP Act was required because these sections of the Indian Penal Code criminalized abortion. Essentially, this Indian Penal Code, which was promulgated by the Britishers in 1860 with all the Victorian mores and moralities, criminalized both the person who would provide the abortion as well as the person who underwent the abortion. When you criminalize something, obviously it goes underground, and when it goes underground, it's not delivered to women in the safest manner possible, because of which maternal morbidity and mortality from abortion rose very significantly. So the government realized that and asked Shantilal Shah, who was a retired bureaucrat from Mumbai, to look at ways to reduce the high maternal morbidity and mortality associated with illegal abortion. So I think this is the first contextualization that I must give you. When the MTP Act was introduced, it was never about access, it was never about women's rights, it was not about giving a woman a right to have an abortion. It was simply to lower maternal mortality and morbidity, and that's why perhaps the Act is worded the way it is. So the Shantilal Shah Committee started working in 1964. They worked for 2 years, presented a report in 66. It finally went to the parliament in 69 and then was passed as the MTP Act in 71. So look at the amount of time it took to pass this act, even when the government wanted to do it. It started in 64 and the act finally got passed in 1971. But how we provide abortions in India is not only dependent on the Act. The Act is just an act of parliament and it provides an overview. The rules are what give life to the Act. That means they tell us how to follow the Act in everyday life. Sometimes actually, the rules have a much bigger impact than the Act itself, and I'll illustrate that in the next slide. Regulations are framed by the state governments and relate to issues involving opinions, reporting, and maintaining secrecy. The important thing here is that the health being a state subject, the government has to have some role in any law related to health. And the power which is given to state government is only in these three things. If the state government issues a gazette under the MTP Act, which exceeds its brief, which has been done in the past and has been successfully opposed, it is actually overstepping its brief and needs to be called out. And then, of course, there is the SOPs. So how we provide abortions in the country depends on the Act, the rules, the regulations, as well as the SOPs. And this is a classic example of how sometimes rules can have a bigger impact than the Act itself. We provide medical abortion in this country because of that one paragraph highlighted in blue in the rules which were framed in 2002. And medical abortions now account for over 80% of all abortions which take place in our country. SOPs are also, of course, very important. And you will see that good SOPs, like the ones from the Government of India, supported by the FOGSI ICOG GCPRs on MTP, which I had the good fortune of drafting when I was the chair of the MTP committee in 2004, have given backbone to how we use mifepristone and misoprostol in the second trimester of pregnancy. So having understood a little of the background of the Act, the need of the Act, why the Act is written the way it is written, let's move on to the amendments. And this is 2002 amendments, the last time the Act was amended. And I'm going to share a screenshot of my calendar with you here. And you will see 6th October 2008. Now, the reason I'm sharing this screenshot is to show you what happened on that day. You will see that I attended a meeting at the Ministry of Health and Family Welfare, New Delhi, on 6th October 2008. And the Act has got amended and passed just a year back. And that's how long it has taken for this whole process to happen. Obviously, a lot of stakeholders were involved. A lot of FOGSians were involved very, very actively, and a lot of advocacy took place for these amendments to come through. And these are some of the publications which I have made. You can see I have published in Hindustan Times, Mumbai Mirror, The Hindu. I've written editorials in various newspapers and publications. I've even published in law journals about the need of the MTP Act. This is, for example, an excerpt from an interview where I was interviewed by the Jindal Global Law School Journal, one of the well-regarded law journals, to ask about my views on the MTP Act and the conflation with PCP-NDT. I have published in the International Journal of ONG on the need for the MTP Act, and I have made several presentations actually to several parliamentarians. And the one thing which we always told them was that the question of abortion should not be an issue in the political arena. When a woman has to make that kind of decision, she should be able to see her doctor first, not her lawyer, which was what was happening before the amendments came through. And the parliamentary panel had already agreed long time back to extend the gestational age limit for abortions. We have even visited the Prime Minister's office. You can see me standing there where we had made the presentation to the person who was in charge of health at the PMO. We didn't meet the Prime Minister, but we did present this letter to the Prime Minister, and we told them that these are all the changes that were urgently needed to ensure that the MTP Act kept up to times in step with technology. We were therefore delighted actually when the Act finally made it to Parliament. And we were even more delighted when we read the draft, because it seemed that except for one thing that we had asked for, making abortion a right for a woman, everything that we had asked for was accepted by the government. It just shows how progressive and forward-thinking the ministry is at this point. In fact, when Dr. Harshvardhan, now I'm not sure you'll be able to hear this, but when he presented on the need for amending the MTP Act, I think for the first time ever, FOGSI was mentioned as a very major stakeholder whose opinion was taken before the Act was amended. So these were the amendments to the Act. You will see that the Act was amended, and then the rules came out, and all this happened in October and September 2021. So what do the amendments say? The amendments first say that medical boards need to be established under the Act itself. Now, this is very, very important, because if you have something under the Act, it means it's the law of the land. Court judgments, etc., then don't matter as much. Very underrated change, according to me, is the fact that now the Act mentions that an MTP can be provided using medical or surgical methods. Did you know that till now, the Act did not mention the methods of providing an abortion at all? This is for the first time that the Act now mentions that you can do abortions both with medical as well as surgical methods. Within the Act, a major amendment took place. And this major amendment was that before the amendments, we needed one opinion up to 12 weeks and two opinions up to 20 weeks, between 12 and 20 weeks. Under the new Act, which is already operational as of today, you can follow this. Up to 20 weeks of gestation, you now need only one opinion. There is no need for a second opinion. Between 20 and 24 weeks, you need two opinions, and the indications are then outlined in the rules. So a major change, I'm sure you'll agree. The word unmarried, which was there in the clause for failure of contraception, has been dropped. Now, you may think that it's not a big deal to drop one word, but it's actually a massive societal change. Because by dropping the word unmarried, the ministry and the government has accepted the fact that unmarried women have sex, unmarried women can get an unwanted or an unplanned pregnancy, and therefore unmarried women also should have access to safe abortion. So you can understand how much societal impact the dropping of this one word has. For the indication of rape, within the Act itself, the gestational age limit has been enhanced from 20 to 24 weeks. And look at the indications for which we are now allowed to do abortions right up to 24 weeks of gestation. If you go through the list, starting from survivors of sexual assault, minors, right down to women with pregnancy in humanitarian settings, you'll see that except for failure of contraception, which is allowed up to 20 weeks, we are perhaps one of the few countries in the world where abortion is legal right up to 24 weeks of gestation for such a wide and really overwhelming range of indications. And most importantly, there is no need for any fresh training, certification for degree holders in ONG to perform abortions up to 24 weeks, and you do not need any fresh registration, reapplication, certification, or even inspection. If you are qualified and if your place of work has a permission to do abortion up to 20 weeks, you're automatically qualified to do abortions up to 24 weeks. Medical boards come into action only after 24 weeks. Till 24 weeks, for the indications I just showed you, you can now perform abortions without going to court or without going to a medical board. The medical board comes into action when there is a fetal anomaly, and only for the indication of fetal anomaly after 24 weeks. And you will see that it's quite easy to form a medical board. The basic requirements are only of a gynec, pediatrician, and radiologist. What has been a bit of a stumbling block is that the state government or union territory has to notify by an official gazette, and all states have not done that so far. I got a call sometime back from a couple in Delhi. They said, "We heard you're active in the space of abortion. Can you help us? Because we need an abortion at 28 weeks for a fetus with major complex cardiac abnormalities." I said, "Well, you're in Delhi. Just go to a medical board and get permission. I'm sure you'll get it." And they said that there's no medical board in Delhi. So I helped them to draft an affidavit, etc. I told them, now you go to High Court. And the ask that we do when we go to High Court now has changed. Previously, we used to ask the High Court for permission to do the abortion. Now you are supposed to ask the High Court to set up a medical board. It is no longer in the purview of the High Court to give permission for an abortion. It's the medical board which has to make this decision. And see what a remarkable change it is. We used to take sometimes weeks and months to get permission. Now it is mandated that when the medical board advises, when your case reaches the medical board, they have to give a decision in 3 days. And if they decide that the abortion is needed, within 5 days of receipt or request, the abortion has to be provided. You can see that this is an absolutely massive breakthrough for those women who were having congenital anomalies detected late and then had to go through High Court and Supreme Court and so on and so forth, take weeks and months, advance in gestation, and then finally get permission. Section 5A has caused some consternation because it talks about punishment. But I think we'll have to wait for a set of model regulations before this can be clear. Some training requirements have changed, which is reflected in the way opinions will be drafted. And there are two new forms. There's Form D, which the medical board has to fill when they give an opinion. And you will see this form is drafted very well. It's a very clear form where the medical board has to clearly say, is she allowed or denied an abortion? The medical board cannot now say, oh, I think this can happen and that can happen and this could happen. And if this happens, then that can happen, which used to happen in the past. The medical board now clearly says allowed or denied with no room for equivocation. And then there is Form E, which we have to fill if we perform an abortion between 20 and 24 weeks. We are, of course, waiting for the SOPs. I hope that they will be out soon. This is a letter sent by the government of Maharashtra where they asked me to lead the drafting of the SOPs for late abortions. At that time, it was more than 20 weeks. And you will see I prepared a draft which went through a board. And then, so the government of Maharashtra already has a draft now. And we hope that this will be sent. I believe it has been sent. And I hope the center takes cognizance of this. In fact, after the amendments came out, I was asked to write an editorial on the impact of the amendments in terms of abortion access. And I was very happy when the government of India released my editorial as an official press note to all the high commissions and embassies all over the world. So even now, if you go to some high commission or embassy websites, you'll be able to read that editorial. You know, sometimes we face criticism saying that perhaps we didn't do enough. Well, you know, you would want the moon, but you're not going to get it. But if you look at the global context, and I do understand a little of it because I've just finished my tenure as chair of the FIGO Global Committee for Safe Abortion, I can tell you that as of now, India perhaps has one of the best laws for abortion in the entire world. Consider the fact that in supposedly the most developed country in the world, the United States of America, there are entire states which don't have a single abortion provider. Texas, the largest state in America, does not have even one abortion provider. Can you imagine an entire state? Imagine Tamil Nadu, Andhra Pradesh, Telangana, or Maharashtra being without anybody who does abortions. It boggles the imagination. It results in this funny situation where people from Texas are now going to Mexico to get an abortion. But of course, the road from policy to implementation is never straight. It is always quite tortuous, but we have to navigate it. And we have to navigate it because abortions, when done by qualified people in the proper qualified settings, is actually one of the safest medical procedure available to mankind. And yet women are dying from the need of such a simple procedure. Just think about it. You know, typically when we start, come out of MBBS and we start our MD, one of the first things that we will do is either an abortion or a gynec DNC. Now we are trusted as a fresh surgical person to do this, not to speak even of doing a medical abortion. We are trusted as complete freshers to do this procedure under supervision. And it's so tragic that women are dying for need of such a simple procedure. We have to end unsafe abortion and we have to end it now. After all, history is her story too. Thank you very much.
Thank you, Dr. Jaideep. It was a wonderful talk, and always lucid. And I think it was confusion to clarity. The new law will definitely contribute towards ending preventable maternal mortality and morbidity. And there are certain gray zones still, because when we talk of medical boards in certain states of India, the medical boards and SOPs are not existing. And secondly, when we talk of medical board diagnosis of substantial fetal abnormalities as such, then of course the medical board will come. But suppose the pregnancy is due to rape and then we talk of reproductive rights of a woman, then we have to go through the court only, through the petition. I hope so. These are the gray zones which have to be addressed. I think yes.
Can I just sort of, just comment on that, Dr. Vidya?
Yes.
Yeah, okay. So there was a reason why we put a cap at 24 weeks.
Yes.
There were two reasons for that. One was that after 24 weeks, so there was a sort of a overview or a study done of all the court cases which had come so far to the court. And they found that post 24 weeks, the overwhelmingly large majority, upwards of 90-95% cases were for fetal anatomy.
Yes.
So the situation that you say about rape will probably not come in so often. And that's why the government said, well, we can't make an exception and we'll cap it at 24 weeks because all the cases of rape, incest, etc. Came to the court before 24 weeks. Okay. So I'm not saying all, but at the very, very large majority, 90-95%. That's why that 24 weeks cap was taken. For these two reasons. One is very few actually make it beyond 24 weeks. So the burden on the court automatically reduces. And the second is, the government didn't want to say that although technically now we are allowed to do abortion throughout the gestation, the government didn't want to liberalize abortion beyond 24 weeks. But it's still, as I said,
Yes.
really a blessed thing.
Yeah. I think we will have a standardized SOPs for similar to all the states. And I must congratulate you for so much contribution in this on this topic, and really you have come out very wonderfully. So I congratulate you, and of course, Dr. Priyankur, who has brought in such a wonderful discussion on platform. I thank you again. Dr. Jaideep, thank, as well as Dr. Priyanku. Thank you very much.
Wow, wonderful talk, Jaideep. Actually, there is some confidentiality issues which gynecologists are also facing.
Yes.
So we will need more clarity on that. And already you're late for a talk, so we will not disturb you now.
He has to go somewhere. Yeah. But really, it requires much more discussion, and I think much queries also. So I think we will have one more sometimes physical meet, and then we will have a discussion on this.
Because there are problems with confidentiality.
Because and punishment also, if we don't maintain.
No, madam, the police is asking for records of the person who's undergone an abortion, and we have to ask the director of health services for a permission before we give. But the police actually harasses, saying that you give the records and all that. So FOGSI, I think, needs to.
Will you suggest a workaround for that?
Yeah.
Because nowadays I'm seeing more of these type of they come to our hospitals bring summons and ask us for the records of the patient. And when we say we need to go through the director of health services before we give the records, they become little unhappy. And then when we go to the director of health services, they do not help us. They do not sign that application which we give, whether we can give the record. So I think we need to, some help has to be given for FOGSI members, because
I'll just tell you, I've just completed a discussion on this because we want to come out with a guidance on this. So working with the General Global Law School and some post Supreme Court lawyers, etc. And it all boils down to what you define confidentiality as. So, for example, if you say that patients sometimes want to make a claim for the money they have spent on abortion, then they need a discharge card. And if you give the discharge card, technically you're breaking confidentiality.
Breaking the confidentiality.
But who are you handing the discharge card over to? Are you handing it over to the patient, or are you handing it over to the Mediclaim company? So if you're handing it over to the patient, then you're not breaking confidentiality because it's between you and the patient. Now, if the patient goes and gives it to the Mediclaim company, that's not your problem.
Yes.
Okay, so technically you're not breaking confidentiality. You understand? So there are a lot of nuances. If the police come and ask you, there is a provision in the Act that upon the appropriate authority asking you for your record, you're supposed to give it. The big question is, are you also supposed to share the code register? Is not. So what you have to do is, when somebody comes to you asking for abortion records, tell them, give it to me in writing, I'll share it with you. Because you're supposed to do that under the law. If they give it in writing, you're supposed to give it. There is no ambivalence about it. Yeah.
Okay. Because I asked in writing and then I gave the records. I was a little worried, but that it may continue.
Once you give it in writing, you're covered.
Okay. Thank you so much.
Thank you. It was a wonderful talk.
Thank you.
Thank you, Priyankur, for the opportunity. Thank you, Monica and Sadapti.
Congratulations, Priyankur.
Sadapti?
Priyankur is
no, Sadapti is not audible.
Hello?
Monica is there.
Yes, ma'am. Thank you, sir, for such a lucid talk. We thank our chairpersons, Dr. Chamila madam and Dr. Vidya ma'am, for being excellent chairpersons and giving us a feedback on sir's talk also. Sir, thank you for enlightening us for newer MTP amendments, which is the need of the hour and every obstetrician should know. We now move forward to another academic event, which is the panel discussion on MTP in high-risk pregnancies. Can we have the slides, please? Ashish, can we share the slides, please? The moderators for the session are Dr. Bharati Rajshekhar madam and Dr. Girija Prasanna ma'am. The next slide, please.
Just a minute, ma'am.
Dr. Bharati Rajshekhar ma'am is the medical director and consultant at their hospital at Hassan. She is also the Karnataka State Vice President and Indian Red Cross Hassan Director. She is IMA Karnataka State Vice President, Hassan OBGY Society Past President. She has many national and international papers to her credit. She is the master trainer of the Coffee Dhira program. We welcome you, ma'am. Our next moderator for the session is Our next moderator for the session is Dr. Girija Prasanna, ma'am. The next slide, please. Ashish?
Yes, ma'am.
The next slide, please.
Ma'am, just a minute. I think there is a network issues there, ma'am. Because it's showing next slide at my end.
I can't see the slide, but yeah. Dr. Girija Prasanna, ma'am, is the president of the Hassan OBGY Society, Karnataka. We welcome both of you, ma'am, as the moderators for the panel. Our expert panelists, and Dr. Kasturi Donimat, madam. The next slide, please. Madam is the president of the Karnataka Society of Obstetrics and Gynecological Society. Please unmute. Please mute everybody. Ma'am, please mute that.
Yeah, just a minute. I'm in the hospital. There is some emergency in the hospital. Just give me a minute. I'll put on my earphones.
Suri madam is the ex-president of. Yes. Madam is also the MCI inspector to colleges all over India. Vashish, can you please unmute everybody?
Everything is inside only.
Unmute, mute.
Please. She is also the principal investigator of international research projects, and she has been an MCI inspector to all the colleges all over India. She is a UG and PG examiner at many universities, and she is the trainer of the for Dhira, as well as the chairperson of the graduation committee, King's Hibli. We welcome you, ma'am. Our panelists for today are, the next slide, please.
Thank you. Yeah.
Dr. Rupa Prakash ma'am, Dr. Shama Devdasan, Dr. Swarupa Rani, Dr. Maya Malia, Dr. Pushpalata, and Dr. Sabita Ramnani. Can we have their introductions, please? Dr. Raj Lakshmi and Dr. Murari Sati. The next slide, please. Dr. Rupa Prakash ma'am, slide, please. Dr. Shama ma'am holds a fellowship in fetal-maternal medicine. Dr. Rupa Prakash madam is from Team Publish and she's the winner of 3 gold medals. She's also the assistant professor at KMC Manipal and she's a former professor and unit head of the OBGY Society of the JJS Medical College, Mysore. We welcome you, ma'am. Dr. Shama Dasan ma'am is a fetal maternal medicine consultant. She has a FOGSI training institute in advanced. मैं कुछ नहीं बोला उधर बोला 1 मिनट लो बात करो. Dr. Swarupa Rani is from Usmania Medical College, Hyderabad. She holds an MS degree from Gandhi Medical College, Hyderabad, and she's a senior gynecologist at Swarupa Hospital, Mancherial. She's also the founder of the OBGY Society of Mancherial. We welcome you, ma'am. Dr. Raj Rashmi ma'am is an alumna of Kastuba Medical College, Bangalore, and the Bangalore Medical College. She's a practicing gynecologist in semi-urban India for the last 20 years with a special interest in adolescent health. She's also running an adolescent-friendly health clinic for the last 10 years. We welcome you, ma'am. The next slide, please. Dr. Maya Mala is the president of KOGA. She has been an organizing committee member of the AKOG 2011. She is a coordinator from Kasargod Oncology Committee. We welcome you, ma'am. Dr. Pushpalata madam is a consultant OBGY at FOGSI Hospital in Mysuru. She is a fertility specialist and laparoscopic surgeon. She is also the secretary of Mysuru OBGY Society. Dr. Savita Ramnani madam is a consultant obstetrician and gynecologist at Ankura Hospital for Women and Children at Telangana. She is the past secretary of Khammam OBGY Society. She has participated at faculty in state and national conferences. We welcome you, ma'am. Dr. Murari Sathi ma'am is a professor in the Department of OBGY Government Medical College, Kottayam. She is also the state coordinator for Food Drug Committee, FOGSI. She is a facilitator of National Medical Nodal Center for Faculty Development at Kottayam. And she is the academic committee chairperson at Kottayam FOG at 2018 to 21. We welcome you, ma'am. I now request the moderators to please carry the session forward.
Very good evening to everybody. I'm sorry there is a little background noise because we have an emergency in the hospital. I hope it's not disturbing you. Am I audible?
Yes, madam.
Yeah. Well, at the outset, I would like to thank Dr. Priyankur for giving us the opportunity to be a part of this very informative webinar. And we have just heard the Doyen, Dr. Jaideep Tank, speak about the importance of safe abortions and the services we need to provide to our women. And we also had the advanced panel discussion on contraception. But now we will be talking about MTPs in high-risk situations. And as Dr. Jaideep Tank rightly said, each of us gynecologists always believe that, of course, let us accept it, that MTPs are the bread and butter of any obstetrician. Is my slideshow visible?
Yeah.
This is the bread and butter, but very often in high-risk situations, we are at the receiving end of brickbats and litigations. So I think it's very essential that we know how to face these high-risk situations and produce and provide safe abortion care to all those women who come to us in need. So if one does not support legal abortion, in effect, one is supporting illegal abortion. That's what Dr. Professor Arul Kumaran did tell us. Is there a disturbance in the background?
Yes, yes.
Yeah, because there has been a death in the hospital and I'm in the hospital. I will just try to move. Just give me a minute. I will move to a quieter place. because I'm in my outpatient. So there is a cardiac emergency, so I will try. Anyway, the features of the amendment have already been explained to you people. I'm not going to go about that. Let us move to the scenarios. Well, when to be safe in any situation, we have to perform the MTP by proper regulations. We need to be registered. We need to do it in the proper site. Sorry. See, these are some of the real life situations we do face.
Madam, the slides, are they moving?
I'm extremely sorry about this. Internet problem with that. Internet is, you give your connection. No internet connection must have either. Just a minute, please. I'm having, yeah. So anyway, as I told you, MTPs are a nightmare in some medical conditions and are being refused in early pregnancy when it is safer than performing in the late or advanced stage. So providing them with safe supervised abortion services to be considered over just refusing safe abortion services merely because of the high risk factors. We need to understand this. So coming to our panelists, which are these high risk group who come to us for MTP? Dr. Sati Murari, please.
Thank you, madam, for asking me this question. All women who are having risk factors for a pregnancy and for the delivery are high risk for MTP also. For example, like a woman with heart disease, NYHA 3-4, if she is a high risk for continuing pregnancy and also delivery, but also a high risk factor for MTP. And there are other risk factors like more medical conditions, uncontrolled hypertension, uncontrolled diabetes, malignancies. Then women of extremes of age, they are high risk. Then a woman with seizure disorders. So these are a few conditions, few risk factors that put a woman into a high risk category. But as madam rightly said, that is all these high risk factors poses risk to the woman as such during MTP, but the risk is more if she continues the pregnancy and the delivery. And no woman should be denied MTP because of this, because saying this. Because it is further risk. I hope
I don't know. My slides are not moving. Dr. Sati, I'm sorry, my slides are not moving because I have to move into the hospital.
I'm clear. Can
you see my slides?
Slide is seen, but it's not moving.
Yeah, it is not moving because I moved away from the OPD and the net is very poor out here.
Okay.
I just really don't know what I'm supposed to do now. Kadame aitama noise alli?
Noise kadame.
I am inside the hospital in the labor rooms. That's why my mobile network is not very strong.
It happens
here.
sometimes.
So I'm not able to share the screens.
Okay.
Because in the outpatient, there's a lot of noise, background noise.
Can someone else share it for you?
I'll have to, shall I try it on my phone? I don't think we can share on the phone, right?
We can, madam. Maybe we can.
You have the edited version, one of you, Dr. Rupa?
No, I don't have really.
I sent it to you by mail today.
Okay, let me just check.
I sent it by mail to all of you.
If Shama, do you have?
Shama, you have?
Yeah, I'll just.
Yeah, Shama also has, Sati has it. I sent it to all the panelists. Problem.
ಇದು ಓಪನ್ ಮಾಡ್ಬಿಟ್ಟು ಮೇಲ್ ನಂದು ಓಪನ್ ಮಾಡ್ಬಿಟ್ಟು ಇದು ಹಾಕ್ಬೇಕು.
ಯಾರಿದೆಯಲ್ಲಮ್ಮ
ನನ್ನ ಮೇಲ್ ಓಪನ್ ಮಾಡ್ಬಿಟ್ರೆ
We'll go home. Just carry that whole thing and go.
Madam, I have shared it in the.
Madam, it's okay.
Ma'am, I have shared it in the group. Somebody can share the slides.
Can somebody please open it?
Yes.
Shama.
4 minutes and it is done. Just give me a minute.
Yes, madam. So I'll just try sharing. Monica?
Just try sharing it, please.
Monica?
Yeah.
Or the team from Corona
Please give
Remedies can.
WhatsApp in the. ಇಲ್ಲ WhatsApp ಅಲ್ಲಿ ಇಲ್ಲ, mail ಅಲ್ಲಿ ಇದೆ. WhatsApp ಅಲ್ಲಿ ಇದೆ.
I think I've started sharing. Is it fine, madam?
Wait, I have to stop share. I have to stop share.
Shama.
Yeah.
I think it's Shama's.
Yeah, Shama, please go ahead. Just go to the that slide where the indications of what are the high risk cases.
Madam. I'll just go into the full screen. Just a second.
The next.
Yes.
Yeah,
yes,
this one.
madam.
So what are the high risk Dr. Sati was just enumerating? Could you go
Madam,
ahead?
madam, I was saying that all the risk factors that woman is having, that put her into a high risk category for continuing pregnancy, and further delivery will be a high risk for MTP also. Like the risk factors like extremes of age, then uncontrolled hypertension, uncontrolled diabetes, vasculopathy, the woman who recently had stroke, thromboembolic disorders. So numerous medical conditions, then heart disease and like heart 3, 4. So numerous conditions then a woman with a scarred uterus. So a number of conditions put her into a high risk category. But as madam said, that is the woman may be having a risk for MTP, but more risk is when she is having we have to see whether she is having a greater risk if she is having continuing pregnancy and future delivery. So we have to see those factors also when you take up a lady for MT. Madam?
Yeah. Just a minute, please. Just put on the light now. It is just we have to go. Yeah. So next we're going to the next. This is the distribution of the high risk pregnancies, and studies here show that though we do MTPs in high risk cases, the complications are quite minimal if we take the proper precautions. Next slide, please. Next slide. So now we have case number 1. She's a 23-year-old lady. She's a gravida 2 para 1 with history of amenorrhea 3 months, 3/12. She has had a vaginal delivery about 2 years ago. She was using condoms, but then now she has presented with abdominal pain for the past 3 days. And on examination, she's anemic. Uterus is 16 week size, irregular and tender. PV os is closed. On the ultrasound, there are multiple fibroids in an intramural one, which is measuring about 7 centimeters, and another intramural fibroid in the lower pole of the uterus around 4 centimeters, just abutting onto the endometrial cavity. And there is a single intrauterine pregnancy of 12 weeks. She has been managed with analgesics, IV fluids, and tender loving care. The pain was persistent, but we put her on analgesics and the regular antenatal drugs, and she was counseled about the fibroids and its complications and was sent home. She came back after about 48 hours with severe pain again, and the couple were wanted an MTP. So the MTP indications were 2, that is causing significant pain, mental and physical pain to the woman, and 5 is a contraception failure. So this was the case history. So next slide, please. So Dr. Sharma, how would you take consent in this particular case?
In this case, madam, this is a case in which we have seen clearly that the patient has got multiple large fibroids in the uterus, and along with a 12 weeks pregnancy, and they have opted for an MTP due to the various causes that you have enumerated. So here, as in any patient who comes to us for an MTP, we should definitely discuss the surgical and the medical management or the methods of abortion. Definitely in this case, we should also offer the concurrent contraception that we can discuss with her. And if she refuses, even if she refuses the contraception, that is what we should be reassuring her, that even if she refuses, she has the right to MTP. That will be respected. So when we go into the standard documentation.
Yes, you can change the slide, Shama.
Yes, yes, madam. Okay, when we go into, yes, it is seen here.
Follow the protocol.
The proper protocols, the standard documentations, whatever it is, even though the amendments are there, the consent form, it's the same that we used to always fill up the forms. That is the form C. This is the same, that is the patient consent form. And after that, now, according to the amendment, that the opinion form, it is a slight difference is there, definitely, due to the MTPs up to 20 weeks. That is only one registered medical practitioner is required for the giving the opinion. So in this case, we have seen that it's a 12 weeks pregnancy. So only the form 1 is needed. Then the others that madam has just shown in the slides, that is this form E. It is when the MTPs are done between 20 to 24 weeks. And the form D is beyond that. But beyond that, we need the medical board members that we need a consensus on that. So these are the standard documentation forms, and here we can we have shown, madam has shown the forms that we usually fill up. This is the form D, that is the report that we'll be sending later on, that is beyond the 24 weeks. Yes, yes. So yes, here, madam, this is the easy flow chart that you can always, any patient who comes.
So this is the form we send to the medical board. So it is mandatory that you follow the protocol of proper registration. The form C, the form 1 have to be put in an envelope, marked secret, and only the code number, that serial number that she has been given in the admission register, that is form 3, should be on this envelope, should be in the custody of the head of the institution, and to be opened only in very few situations, like when the lady asks for a medical certificate herself, or there is a direction from the court for any other reason. It's only then that the medical officer could open that. So this is what we want to put across. Next slide. So this is mandatory. Next slide, next slide. Next, yes. So Dr. Rupa, how would you counsel this patient before you do an MTP?
Yeah, as in any case, counseling is very, very important, because we need to be safe and patient also needs to be safe. So pre-procedure counseling includes ensuring privacy, and then we need to be non-judgmental. We need to establish a good rapport, make the woman feel very comfortable, though it is not right. Make her feel comfortable, use simple language. So explain in her own language, and ask her, allow her to clarify any doubts if she has. And very important is that you have to take an informed consent in prescribed format, explain the procedure, and very, very important is that prior to MTP, you should advise them contraceptive advice. Now, in this case, since it is 3 months already, that is 12 weeks, there is no role for medical method. It is always a surgical method. And then first trimester considered still as first trimester. And we need to really counsel her about the problems that may happen with surgical procedures because of the presence of fibroids. So you tell her about the available options, especially the surgical method here. And then medical, of course, is ruled out here. And consider also about management of fibroid along with the surgical procedure that could be done. Here, the fibroid is too low in the lower uterine segment. So we really don't know if we will be able to do a vaginal procedure for her. Probably it should be done under ultrasound guidance for completing the procedure. So everything should be told in detail about the complications, about the hemorrhage, need for blood transfusion, and about the, either laparoscopy or laparotomy in case we land up with a complication. So this is not a very simple, straightforward case. So we need to really counsel her well, reassure her that all facilities are present in our own hospital, due care should be taken, and see that we don't land up with the problem during the procedure.
Yeah, thank you, Rupa. Next slide. Next slide, I think, yeah. So role of ultrasound. Dr. Rupa just mentioned that you have to have an ultrasound. So what is the place of ultrasound, Dr. Swarupa?
Yeah. Ultrasound has a very limited role in MTP that's advocated by the law. Am I audible?
Yeah, you are. Next slide.
It is not mandatory or binding upon the clinician to advise or perform the ultrasound before undergoing MTP. But as in this case, where there were multiple fibroids, only with 12 weeks of pregnancy, the uterine size was 16 weeks. So we understand the role to document the pregnancy, to date the pregnancy, and also to diagnose any coexisting mass like fibroid or any uterine anomalies. In case of scarred uterus, you can make out the thickness of the scar or also the scar, ectopics, and any molar pregnancies and ectopic pregnancies as such, which can be a tubal or ovarian. So these all we can find out, and also in the follow-up, wherein post MMA or anything like that, to make sure that the abortion is complete and there are no RPOC, no retained products, and even to diagnose gestational trophoblastic diseases, and any perforation post MTP also can be diagnosed, and any suspicion of heterotopic or ectopic pregnancy can be made out using ultrasound.
So as said, I think in this case, because she has multiple fibroids, ultrasound definitely has a role, though routinely in the case of MMA in an uncomplicated pregnancy, there is a limited scope for ultrasound because there are many centers where there's no facility for ultrasound, and just the non-availability of an ultrasound should not defer the medical termination of pregnancy in an uncomplicated case. Next slide. Yeah. So Dr. Rajalakshmi, what method of MTP would you adopt in this case?
Good evening, ma'am. As we are discussing high risk MTP in high risk cases, she is a gravida 2 with a uterus with a irregular cavity. So actually we can try with medical method, according to me, because surgical method, it might be difficult to find the cervix and use the instruments. Maybe under ultrasound guidance, it will be easier, but the researchers say that we can try the medical method of termination with these patients.
Yeah,
where
definitely.
the cavity is irregular.
Yes, because the cavity and technical difficulties, I think we try medical method of abortion for this lady, explaining to her the problems, and of course keep her under supervision.
Yeah,
because
she's anemic, so we have to be little careful.
She is prone for complications like an incomplete abortion and excessive hemorrhage and pain. Next slide. Next. So what is Rajalakshmi? What would be the protocol you follow for her?
The medical method, where we'll first day give the MMA drugs can be given in a registered practitioner in a registered place, and we have to tell her that she might bleed, and we have to tell her where, in case we are giving it in a clinic, we should tell her where she should come if she bleeds more, and better if it is in a in-house, if she gets admitted. I'll give her mifepristone on the first day, that is 200 milligram orally. And after 48 hours, we'll give her 800 microgram of misoprostol, either vaginally, buccally, or sublingually. And call up for follow-up after 15 days.
Yeah. Next slide. Yeah. No, when you're giving her, unless she's in-house, I think the follow-up, she will come on day 2. On day 1, you have administered the drug. She needs to come on day 3. Next slide, please. She needs to come on day 3 for the misoprostol. And then she, next slide.
Come on the 15th day for the follow-up.
This is the follow-up protocol. I will ask Dr. Maya to, I don't know if Dr. Maya is here because she said that she will be on the train. Dr. Maya, are you here?
Yes, madam. Can you hear me?
Yes, Maya, we can definitely hear you. So you could go over with the follow-up protocol for these women.
Usually, during first day,
Maya, please put off your video and speak. Put off your video, you will be convenient. The network will be better. She's also traveling. Yeah, I think now you can speak. Dr. Maya, are you there? If she...
Can you hear me?
Dr. Swarupa?
Yes.
If Maya is not audible.
Can you hear me?
Yeah, now we can hear you.
Yeah,
Please
now
go
we
ahead.
can hear you.
Yeah, on the first day, we have to do the counseling first properly, and we have to take the informed consent. Then we have to do the physical and pelvic examination, and we have to confirm, we have to give the mifepristone 200 milligram on first day. And we have to advise where she has to come when if she gets any complications.
Yeah, I think
so
that
then,
Dr. Rajeshri has told, could you just go to the follow-up advice for paucity of time?
Yes, follow-up advice on day 3. I have to again confirm whether she has started bleeding. If she's having pain, we can stick, and we can give the mifepristone 800 milligram either vaginally or sublingually.
Yes. And then, because she's
And
a case of
she has to be
fibroid, would you wait
hospitalized
up till
for
15
at least
days?
4 hours.
Huh.
Hello?
Yes, Dr. Maya. So generally, you would ask them to come back on day 15 in an uncomplicated case, but probably because this lady has multiple fibroids, you would like to ask her to come earlier, but never forget to give them this MMA card, which is available in all public hospitals, and we need to, Shamapi. This is the MMA card we need to give to them and ask them to put down the expected symptoms and mark it out on the card. So could you elaborate on this, any one of you?
Yes. Yes, whether she is having spotting, whether she is having normal bleeding, or she is having nausea and vomiting, and if she is having pain, fever, chills and rigors, that she has to put it in the card.
Yeah.
How much she is having, the symptoms. So from 1 to 15 is the grading. And if she is having excessive bleeding where she is unable to tolerate, she has to come immediately. And if she is having excessive weakness or the pain also, she has to come to us.
Yes, thank you. Next slide, please.
And a
so
scanning is a must.
Yeah, we need to remember here one thing, when we give them the first tablet of mifepristone, some of them do have spotting and many of them fail to take the misoprostol. So it's a good advice to call them to the hospital and give them those 3 misoprostol tablets practically, because we have seen women skipping their misoprostol dose and come landing up with incomplete abortions or a continuation of pregnancy. Next slide. Yes. So Dr. Pushpalata, what are the contraindications for the MMA? I'm sorry for the spelling mistake.
Good evening, everyone. So the contraindications being unsuspected or ectopic pregnancy. So the undiagnosed adnexal mass and severe anemia, like hemoglobin less than 8 g/%, uncontrolled hypertension, if she is having a severe cardiac problem. So NYHA more than 2, like severe valvular disease, angina or arrhythmia, severe renal, liver or respiratory diseases, and she is currently on anticoagulant therapy and inherited porphyrias and uncontrolled seizure disorders, and of course glaucoma, if she is allergic to any of the component like mifepristone, misoprostol or any other drug allergies.
Yeah. And this is MTP focus on by the FOGSI by Dr. Bharti Maheshwari. It's a very good ready reckoner, which I would advise all of you. Along with this, there is one provider NHM publication on the checklist and the training manual for MMAs, which is a very good ready reckoner for all of us. Next slide. Thank you, Dr. Pushpa. And these are some conditions where you need to be cautious, though it can be used with caution, like bronchial asthma, pregnancy with IUCD. So Dr. Sabita, and this particular case, pregnancy with fibroid, you need to be cautious. So if there is excessive bleeding on the 3rd day or the 7th day, how would you manage, Dr. Sabita?
Thank you, madam. We should assess for the presenting symptoms if that bleeding is heavy and continuous, and we should ask for the symptoms that are associated with pain abdomen, like we'll see in a rare case like a post-abortion syndrome, where there will not be any bleeding per vaginum, but there is a distinction in the uterine cavity and the patient presents with fever. So we should assess for the hemodynamic instability if at all. And we should categorize the patient whenever she comes with excessive bleeding, whether if she is stable or an unstable patient, like if there is a hypotension, tachycardia is there, and we should check for the vital signs. And if at all she is in an unstable condition, ensure that her ABC is maintained, that airway patency has to be maintained, and oxygen mask should be put up, and a secure IV line with 18 gauge cannula should be secured, and crystalloid should be infused. And if you suspect an atonicity of the uterus, oxytocin, and in case the patient presents with a high-grade fever we should start off her with antibiotics and all. And in case if she is not stabilized, we need to refer to a higher center also. And if you stabilize the patient, then go for the ultrasound scan to rule out the cause for this heavy excessive bleeding. And if you find before going for the ultrasound, even if you can do a parvaginal examination, if you can see, if you can feel the products of conception, you can as well do a digital evacuation also. And if you don't find any vaginal products of conception, you can go for an ultrasound to look for retained products of conception. And if you find retained products of conception and there is no sac, like only placental beds are there, you can advise a repeat dose of misoprostol, and you can ask for the follow-up after 7 days. And if you find a gestational sac, you can as well go for a suction evacuation one. And follow-up after
it's a viable pregnancy. If it's a viable pregnancy, you do not repeat the dose. You need to refer them to a higher center. Or if you are itself in a secondary or a tertiary care center, you can go for alternate methods of MTP, like surgical evacuation. So, Dr. Sati, what are the other MTP options we have other than MMA in this case?
Madam, in this case, that is this case of fibroid uterus, it's a very tricky situation. This medical abortion, if she is having any retained products of conception, it's showing, then we have to do an ultrasound, and under ultrasound guidance, we have to do a suction evacuation. Because she is having multiple fibroids, they will be unable, I mean, it's very difficult to find out, negotiate the cervix, then negotiate the cavity and all. But in general, when we are speaking about the surgical method, like actually previously we had a menstrual regulation, that is within 42 days. But all this that has been taken up, that place has been taken up by medical MMA, because and with the MMA there is like wide acceptance by both clients and also us doctors, because it's easy to administer, then very successful if correctly used.
Next slide, please.
And less side effects. And less side effects.
So these are the other options.
So the surgical methods. But we cannot go away with everything by medical methods. So we have to have surgical methods. For first trimester, we can have the suction evacuation. Suction evacuation can be either by manual vacuum aspirator, or by electrical suction we can use. Then manual vacuum aspirator is said to be very good. WHO and FOGSI has advocated and can be used in low resource settings. Then for second trimester abortion, then we can have a dilatation and evacuation using both suction and using one forceps alternatively. Then mainly medical for second trimester, but surgical can be used. Then the final resort is hysterotomy, and hysterotomy is not done. You should only when everything fails. And
so it's more of a vacuum aspiration or a dilatation and evacuation. So next slide, please.
Yes.
Next slide. Yeah. So what are the difficulties? Any of the panelists can take this question. What are the difficulties you encounter in such cases?
So in this case, particularly, we may not be able to negotiate the cervix at all, because fibroid is in the lower uterine segment. So that is the first thing. Second thing is bleeding, because uterus doesn't contract well. So we should be ready for that bleeding also. And third, in case we're not able to manage it medically or surgically, and then we open up the abdomen, we may not be really able to do it with the incision on the lower uterine segment, because fibroid is there in the lower uterine segment. So we should counsel the patient that we may have to do a myomectomy also along with it, because it is not wrong to do. We do myomectomy along with cesarean section. So we probably may have to take consent for myomectomy also.
So, as rightly said by Dr. Rupa, excessive bleeding, pain, incomplete abortion, and perforation and technical difficulties are there.
Yeah.
So, let me say what I did in this particular case. Well, she came with persistent pain, and because she was already in pain, I primed the uterus, I primed the cervix, and then later on I did a suction evacuation under ultrasound guidance and general anesthesia. We did have difficulty in manipulating the cannula through. So then we did the evacuation and we sent her home. She came back after 10 days with excessive bleeding, PV, and pain again.
Yes.
So when we examined her, there were some retained products of conception in this woman. So immediately we did, as Dr. Sati said, there were some products presenting at the OS. We did a digital evacuation. Then under ultrasound guidance, I did a gentle suction evacuation for her, put her on antibiotics. We had to give her blood transfusion and kept her in the hospital for 48 hours. But bleeding stopped, patient was stable, but her pain was persistent. And she was not able to tolerate with all proper standard analgesics, and they wanted me to do a myomectomy. So after explaining all the risks, taking consent for hysterectomy, I did do myomectomy. We were able to successfully remove both the fibroids. One was about 8 centimeters and the other one was about 4 to 5 centimeters. And the bigger fibroid had undergone red degeneration, probably. That was the reason for her intractable pain. And patient is stable and went home after 3 days of surgery. And we have sent her with contraceptive advice, asking her to come back after 4 weeks for contraception. Next case, please. So this was just about 2 weeks back. So now I have my co-moderator, Dr. Girija Prasanna, who will be presenting the next case.
Good evening, everyone. Hope I am audible. I thank the organizers for the opportunity, also Bharti Madam. So you all know that there is a rise on cesarean section, and it's been a very hot topic of discussion. So we do come across cases of scarred uterus for medical termination of pregnancy. So this case is about MTP in scarred uterus. Here is a woman of 28-year-old with amenorrhea of 13 weeks, and she's gravida 3 with previous 2 LSES. And that too, last LSES was just 10 months back. And she got intracesarean IUCD inserted, but then she got it removed because of abnormal uterine bleeding. The couple were using, husband was using condom, but then it failed and she got conceived. So it comes under class 5. So her blood group is B negative. She is a negative, this one. So how would you proceed? Can I ask Dr. Sabita?
Yes, ma'am. This case comes under high risk because she has multiple incisions on the uterus, and her last childbirth is less than 1 year. And there are chances of scar dehiscence and scar rupture. So I would like to take a detailed history regarding the previous intraoperative and post-operative history of the previous surgeries, like if there is any history of upper segment incision, the duration of the previous surgeries, and there is any history of infections in the post-operative period, which will weaken the scar. And I would like to do a scan to look for any scar ectopic in this case, and to look for any abnormal placentation. And I would like to see for any anomalies in the uterus. And I would like to take a history regarding any associated medical conditions in this case, like diabetes, hypertension, asthma, and thyroid, etc. And I would like to go ahead with the ultrasound guided procedure in this case, as chances of scar dehiscence or more. And if at all, if ultrasound guided procedure is not available in that, even I can advise them to go for post procedure ultrasound to look for any RPOC in this case, ma'am.
Yeah, thank you,
like
Dr.
concept
Sabita.
regarding the post-abortion contraception also in this case.
Yeah, yes, rightly pointed out, Dr. Sabita. In this case, ultrasound is a must. Though MTP rule says MTP, so ultrasound is not required for MTP, I mean unscarred uterus, but then for scarred uterus cases, we have to get ultrasound done. Main thing is to rule out dreaded situations like scar ectopic and the placental accreta syndrome. That's very important. And then what are the other high-risk factors would be considered? These are the things which we need to keep in mind, because all those histories, whatever you said, duration of surgery, all that is important to ensure that the scar, how sound it is. That's very important. And what are the other high-risk factors? Yeah,
Next
that is
slide. Yeah. Next slide.
So in this woman, since it's a scarred uterus, which method would you suggest, Dr. Rajlakshmi, for MTP?
Dr. Rajlakshmi, are you there? Dr. Rupa is
Once
there.
I rule out gestation scar ectopic, even though it's a scar uterus, there is no contraindication for medical method. So I would go ahead with the medical method. Only thing is when I'm prescribing misoprostol, I'll be a little careful. The interval between the dosage will be more. Yeah, interval between the dosage will be more and the quantity of the drug will be less. So instead of giving 400 to 800 microgram, we'll give 200 to 400 microgram. And instead of giving every 3 hours, we can give it every 6 hours. So,
next slide, Shama. We have it there.
Yeah.
Next.
So there is no though there is no clear recommendation, but the evidence says the usage of misoprostol is not contraindicated in a scarred uterus. That's very important. Yes. So start with the lower dose and then increase the dose interval. That is the message to be given here. And before increasing the next dose, one has to assess, individualize the case. Depending on the response, one need to decide regarding the next dose of the misoprostol.
Yes.
Thank you, Dr. Rajlakshmi.
Yeah, thank you.
What about a place of surgical method in a scarred uterus, Dr. Sabita?
Yes, ma'am. We can go for the manual vacuum aspiration or an electric vacuum aspiration. And
So
there is
precautions would you take because it's a scarred uterus?
Yes. Even we can go for dilatation and evacuation, and we should counsel the patient regarding the need of hysterotomy in case any scar dehiscence is there, or
last resort. Yes.
Last resort, we should counsel the patient, and if there is any scar dehiscence, or if the patient is hemodynamically stable and you suspect dehiscence, we should go for laparotomy and hysterotomy as a last resort.
I think so. Here, it's very important to have a cervical preparedness, that is pre-procedure cervical preparation, because it's a scarred uterus. It's all the more important. So can I know from Rupa Prakash ma'am about this?
Actually, any surgical method, it is always safer to prepare cervix. And it is all the more important when the uterus is scarred, whether it is cesarean section or myomectomy or previous. So the best method nowadays is misoprostol has come as a boon for us. Earlier we had laminaria tents, but somehow they're not freely available now. But misoprostol has come as a boon. Insertion of 2 tablets of 200 micrograms vaginally 2 to 4 hours prior to the procedure gives us excellent dilatation and makes the procedure less painful and less complications. But I would suggest that it is always best to do it under ultrasound guidance, so you know that you are not perforating the uterus.
Even other Dilapan is available, which is a synthetic osmotic dilator. So though it is not freely available, used in a scarred uterus.
And it is expensive.
And expensive, but then misoprostol would be ideal. As Madam said, it's a boon for us. So it makes our life very easy. Evacuation will be very easy. So abortion process, uterus also starts contracting and it helps in cervical dilatation. Abortion process is initiated. It shortens the duration of the procedure as well as good outcome, and pain also will be less. Thank you, ma'am.
Dr. Rupa, if you remember, I would just like to add a comment here. As postgraduates, we did not have the benefit of having these drugs. We had intraamniotic saline instead, ethacnidil instead, and in spite of all these things, the woman would never dilate. And that was the scenario when we had to, unfortunately, do a hysterotomy. Now I think it's a forgotten art, and I think we should not be, never do an hysterotomy.
I also remember use of bougie
Yes,
red rubber
exactly.
catheters, one after the other, 3-4 bougies we used to put in the extra
And
amniotic
then
space.
sepsis and no response, and then we had to land up. But I think nowadays hysterotomy should not be there at all in the protocol.
Yes. And this woman is, since she is Rh negative, what about anti-D prophylaxis for these women who were undergoing MTP procedure? Dr. Sati.
Dr. Sati, are you there? I think she's also traveling. Swarupa can take the question.
Yes, madam.
She's there? Yes,
Yes,
Sati,
madam.
please.
Yes. So she is Rh negative. Actually, depending upon her husband, her husband may be, Rh positive, isn't it?
Shema, please move the slide. Thank you. Yes, Sati, please go on.
First trimester. So if we are, anti-D need not be given in first trimester if it is a spontaneous abortion, but all therapeutic abortions need anti-D. In first trimester abortion, the dose is less, around 50 microgram. But in second trimester abortion, then 300 microgram has to be used. All therapeutic intervention, all therapeutic abortions, we have to give anti-D. Anti-D has to be given even if medical method is followed. Anti-D has to be given in the first, along with misoprostol. If the lady is not coming for coming to hospital for misoprostol, then we have to give it in the first day itself when we are giving mifepristone.
Yeah.
Okay.
So yes, madam.
Yeah. What about the role of antibiotics in this case, Dr. Maya?
Dr. Maya, are you there? No, she's not. Anyone in the panel can take up the question. Answer, please.
Yes, madam. When you talk about antibiotics, if it is following the medical abortion, that is the method, the risk is very low for infection. So that way, usually prophylactic antibiotics, we do not give the patients, but definitely in cases of surgical abortion, as herein, then definitely we should be starting a routine antibiotics should be used because almost by half the infection reduces. So there should not be delay also. And usually what we provide here, as in here it is doxycycline within 2 hours before the procedure, and then we give it off on an OPD basis. They have to take it for the continuous 7 days. So that is what usually even in our setup, we do use doxycycline 200 milligram.
Yeah, I think that message is there. But medical abortions, there's no necessity, especially
to continue
to give them antibiotics.
Yes, madam. Yes.
What about the post-abortion care, Dr. Pushpalata?
Yes, ma'am. The post-abortion care is very important in the scarred uterus. Initially, if she is admitted, we need to observe her for 48 hours for any excessive bleeding if she has undergone a surgical evacuation or any fever, like excessive pain. So, while advising, you should treat with the antibiotics and analgesics. And if she's in the second trimester, you can advise her breast binding and a lactation suppression too. And while discharging, we can advise her counselor regarding her contraceptions. Usually, we advise her to return after 15 days. But if she has to return early, if she has a severe pain, if she has a foul-smelling discharge, vomiting, upper abdominal pain, and severe fatigue,
you need to return back early. Yes. Yes. Thank you. Next slide.
I think our panelists have managed this patient very well. And now we come to another very unique case, which was a case in our hospital a month ago. She's a 23-year-old girl married for 1 year, a primigravida with a history of amenorrhea of 5/12. She was using contraception. She was using condoms. And once we examined her and we were counseling her and we examined, she's having a uterus of 16-week size. Ultrasound was done elsewhere and she came with a 16-week size uterus. And she said that she is suffering from sickle cell disease and it was diagnosed in adolescence. She had the sickle cell card with her and she had her last transfusion about 10 years back. And later on, she has had an uneventful course. And MTP was done because of the contraceptive failure under the clause 5. Next slide. So as you all know, sickle cell disease is a very common scenario. When I was speaking today morning to Dr. Sati, I said in our part of our Hassan, where I come from, sickle cell disease is a rarity, but many cities, many areas in India, especially the tribal belt, Maharashtra, Bihar, UP, this girl happened to be from UP. This sickle cell disease is an increasing global health problem and one of the most common genetic disorders. And what does it cause? It causes vaso-occlusive symptoms because of the deoxygenated hemoglobin S undergoing polymerization and associated with significant maternal mortality and morbidity. And because of the loss of oxygen, we have all this pain crisis of hypoxia, stasis, and pain. So these are the common scenarios of sickle cell disease. Next. So in this particular case, she came to, and of course she had already a diagnosed card. So when we are taking the history, if they give us history of repeated attacks of pain or ulcers on the leg or swelling of the leg, or she's having chronic anemia, we have to think of sickle cell disease, especially when demographically we take the history of from which region she comes from. This girl happened to come from Bihar. She was a migrant, immigrant working in one of the companies here in Hassan. Next slide. Next slide. So that is how. So what are the complications? All of you know there's increased maternal mortality and morbidity, fetal mortality and morbidity because of the vaso-occlusive symptoms. I'm not going to go into elaboration. Let's now just deal with the situation. The couple have come for a medical termination of pregnancy. Which method would you offer, Dr. Swarupa? Dr. Swarupa, are you there?
I'm there. Yeah, being a primary and now 20 weeks, I think
16 weeks.
Ideally,
16 weeks.
So 16 weeks. Ideally, it should be managed by medical method alone. We should counsel her regarding all the complications, and medically we can use misoprostol and tablet.
Yeah, the same protocol. Mifepristone day 1, day 3 misoprostol. Well, Dr. Rupa, keeping in mind of sickle cell disease, what are the special precautions you would take?
So special precaution, the problem with these people is the vaso-occlusive problem. So if patient is on low molecular weight heparin or ecosprin to prevent this, she should be advised to stop that first. And then dehydration and hypothermia are to be avoided. So adequate hydration, avoiding hypothermia is encouraged. And hypoxia is really a problem for them. So during the procedure, SpO2 has to be monitored, and in case there is less saturation, oxygen needs to be supplied. They're more prone for infection, so antibiotic is a must. Analgesia is also should be given adequately. And because they're more prone for these vaso-occlusive problems and thromboembolism, early ambulation and prevention of these problems by hydration and good pain relief is a must. And so whatever it is, in case we need to start them on anticoagulants, it should be started after about 7 days. So very important to manage them in the postoperative period.
Can I go back to the slide? So let me tell you what I did for this lady.
Okay.
So we did this not as an outpatient setting. Obviously, you could not do it as an outpatient setting. She was admitted, and we had the SpO monitoring. Counseling was done. Adequate hydration with IV fluids was given, and her oxygen saturation was monitored continuously with in the HDU where piped oxygen was available in case there was an emergency. The staff were sensitized because this is a very rare situation. So I had to train my staff to monitor her, why she had to be monitored. And we gave her analgesia with paracetamol. Fortunately, within 48 hours, the MTP process was complete. I kept her for another 24 hours, put her on low molecular weight for 7 days and sent her back with contraceptive advice because she does not want to conceive for the next 2 years. We have asked her to come back to use some IUCD, preferably as a contraception. That's what I've done for her. So now, Dr. Pushpalata, how would you counsel this couple?
Actually, she has a known sickle cell disease. As we know, the sickle cell disease is an autosomal recessive disorder. Testing our partners become very important to know whether he is also trait or he is a full-blown sickle cell disease. So after that, we also need to counsel her regarding a contraception, especially a progesterone-only contraceptive pills or Mirena. So, or barrier contraception. You should avoid either the IUCD or any other. So then you should, like for the further future conception, you should ask her to consider the genetic counseling before she conceive in the next pregnancies. So because this is an autosomal recessive, if she is She's a sickle cell disease. So if her husband is also a sickle cell disease, then she's having a chance, 100% chance of all children being a sickle cell disease. If he is a trait, then 50% of them will be a sickle cell disease and 50% will be a trait. If her partner is a normal, then all her children will be a trait. And if that is the thing we need to explain her.
Yeah. And I think once she conceives, she will need a genetic analysis either by NIPT or a chorion villus sampling to find out whether the baby is affected, and explain to the couple about the eventualities of the disease or the trait. So, Dr. Sharma, what contraception would you advise? Though you've already touched on it.
We just touched on it, madam. The
we just touched
contraceptive
on it. So the
advice,
POP,
ideally,
yes.
that's what the progesterone only contraceptives. That is what we would consider the most
Yes.
safe, so that there are no venous or arterial thrombosis changes in that. So basically, it would be the progesterone only pill, Mirena. Then, if they are not willing for any of the contraception via the hormonal, we can always offer the barrier method also to them.
Yes.
Though WHO does recommend, madam, that even low dose OC pills, combined pills can be given, but in our part of the country, what we usually prefer is this. Yes,
So they don't come back for follow-up and they are not consistent with their
Estrogen for a
symptoms.
long time
So
is
it's
not
safer.
good.
I would say the Mirena would be the safest option. With the POP pills, they will not take it properly.
Pills, yes, madam.
Yeah, next. So this lady was managed successfully and we were able to send her home with contraception, and hopefully she should have an uneventful pregnancy next time. So now Dr. Girija goes on to the
moving
next
on
case.
to the next case. She
Please
is
tell us,
20
let us know when we need to stop, Dr. Monica. Yes.
Yeah. She, moving on to the next case, she is a 20 years old primey with a history of 2 months of amenorrhea with newly detected severe mitral stenosis during her antenatal checkups. She belongs to NYHA class 4. She at rest, she is breathless. So advised MTP. Okay, and category 3, class 3. So what precaution would you take, Dr. Rupa Prakash ma'am?
Yeah, actually, this is a very tricky situation. Young primey, usually in a primey, we never advise termination of pregnancy unless it is really deleterious for her health. But somehow she has landed up with grade 4, New York Heart Association grading because of tight mitral stenosis. So whatever it is, even if there is a valid indication for termination, first of all, we should, it is a teamwork. Yes. Obstetrician along with cardiologist and intensivist have to manage this because it is always a problematic here. So first of all, her cardiac status needs to be improved before we embark on any of the procedure. Next slide, please. So they require extra care because they are more prone for complications. Especially in this case, she is grade 4. So if we don't take care, there is always a chance of mortality. There may be certain drugs that we use for the procedure which could be detrimental for her cardiac status. Intravenous infusion of oxytocin at high dose may result in fluid retention because it is similar to vasopressin. So it may result in fluid retention, resulting in pulmonary edema and maybe congestive cardiac failure or congestive heart failure. Methyl ergometrin and prostaglandin F2 alpha, they have potent vasoactive, vasoconstrictive action. So it can lead to sudden hypertension. So we cannot use it. So a patient has to be managed with cardiologist, anesthetist, intensivist in a tertiary care center where there is a facility for an emergency valvotomy in case patient lands up with trouble. So do not do it as an outpatient procedure. Do not do it in an ordinary hospital where ICU, CCU, cardiologist is not there. Women with anticoagulant due to prosthetic valve. This is in general. This patient does not have any valve. So because of the increased risk of hemorrhage, we need to discontinue this. Otherwise, it can result in life-threatening events like atrial fibrillation and thromboembolism. Mifepristone and misoprostol are not commonly used for elective abortion in women with cardiac disorder. So what are the methods we are left with?
Yes,
So
Dr.
which method
Shyama.
would be ideal? So it is multidisciplinary approach in a tertiary care center.
Yes.
So is the
Yeah, and I think
approach.
Dr. Rupa, we can always even tell her that she can always undergo a mitral valvotomy and continue the pregnancy.
That's what I wanted to tell you, that
Because
we
it's a
first,
primary gravity. Yes,
no,
madam.
I feel we should first correct her cardiac status.
Yes,
And then
and
give her
continue.
the choice, in case she improves, give her the choice of valvotomy in the mid-trimester and see if she tolerates the procedure, we can continue with it as well.
Yeah, I
Just
think that
because
also
she is
we
in,
should,
we should think of that.
yeah, think of that. So Dr. Shyama?
Which
Yes, madam. Just like now Dr. Rupa madam had just mentioned that medical methods, usually we do not go ahead with the MIFI and the MESO protocols. And in this case, as we can see, she was in NIHA 4, that is cardiac failure. And with the team approach, after we stabilize the patient, she's in the first trimester, I would go in rather for a surgical evacuation so that it is quicker, madam, than, the medical abortion. The process itself, though the patient is inpatient, we have stabilized her. The process of medical abortion, we do not have a control. The patient may go in for a bleed, a hemorrhage, and we might go in to lose the patient. So what I would prefer in such a case, definitely that, we go in for a surgical evacuation quickly in the OT with our entire team at hand, so that maximum a single dose of PGE1 maybe we can keep prior, so that to prime the cervix, as it was mentioned earlier, we could keep in a single dose of PGE1. That is what
We would also, I think the moderators also go with you, and I think, I don't know, the other panelists, we will go for a quick surgical evacuation.
Yeah, that is better. That is always better and more predictable, especially
Yes,
with ultrasound guidance.
Yes, exactly.
Yes, madam.
Yes. So now we have one of the very tricky situations which we come across very commonly nowadays, and we have Dr. Girija to take over the case. Oh, no, anyway, I'll go ahead. Okay.
So no problem.
Yeah.
So we do come across, since I'm working in a government institution, we have a FOGSI cell there. We do come across such cases quite often. This girl had come last week itself. She was just 13-year-old and she gave a menorrhagia history of 3 months, but then on ultrasound, it was about 16 weeks pregnancy. So what are the procedures to be followed? She's below 18 years old, so it comes under FOGSI Act. Dr. Swarupa?
Yeah, madam. The very essence of MTP Act is the safety of the woman and the girls. And this, because the MTP law, earlier it was supporting 18 years, more than 18. Because she is below 18 and being a minor, this comes under FOGSI Act, where every minor who is pregnant need to be offered MTP, and also they have to we have to inform, as a provider of the service, we have to inform the nearest police, and we need not wait till the investigation is completed, and we need not file an FIR, or we need not do any investigation. Only thing is we have to inform the police and do our duty. We can take about the MTP even before the investigation is complete. And apart from that, we have to preserve the products. Products have to be preserved in case it is needed for the forensic examination. We have to preserve it in saline. Within 72 hours, we have to inform the police to collect the specimen. This is utmost important. And if it is a rape, again, it forms an MLC, and it becomes mandatory for us to inform the police.
Very important, please retain the products of, preserve the products of consumption, and make it a point to inform the police and take an acknowledgement from, the police, right? So they will, if we just give them a verbal or a phone call, they will say, nobody called me tomorrow. So see that somebody takes it from a responsible person from your hospital, takes a written requisition to the police station, and they have an acknowledgement with the sign and seal over there, and that will be the evidence for you in case the police do not, very often they do not come up to pick up the specimen, and when the evidence is there in the court, you will be liable for punishment. So you are safe when you say that I have informed the police station on such and such a day. I did send a reminder for them on the second day. They did not come. The products were preserved in normal saline, they decomposed. So you are safe in the hands of law.
Also, I would like to bring.
Also, should we send that part of the specimen, especially in first trimester when no fetus is seen for histopathology?
Yes. Whatever you aspirate,
product needs to be mentioned.
That is why they have to be kept in the hospital and given the MMA, because you have to take the products of conception.
MMA, in the first trimester, in case if she expels in the bathroom or something, you may not get the product. That's the problem.
Correct.
And then in case if girl denies, to reveal the name of the culprit, or if she is not willing to send the product for DNA analysis, that has to be documented, and we need to respect her.
Because that is, I think, especially if the girl is above.
Confidentiality has to be maintained.
In the MTP Act and the POXO Act. So she can say if she's been having consensual sex, she can always deny, saying that I do not want the name of the accused to be revealed. I do not want the products of conception to be preserved. But that has to be documented in the presence of a major individual. Guardian or whoever has come with
preferably a video consent.
Yes, whatever about video, along with documentation has to be done in that case.
Written in our own handwriting is always preferable.
Yes,
Coming to the present day scenarios of litigation times.
Yeah, you have to be very, first save your skin.
Yes.
Save others.
Correct.
Need of the hour.
No shortcuts, don't go too much of power, humanitarian. Oh, my such a small girl, what will she do? I think we'll have to reserve that for other situations.
In case you are not preserving the products, and it can be punishable, like you are not taking any documentation, like you are wiping off all the men's
evidence.
You are meddling with the evidence, so it is really punishable offense.
Correct.
Exactly.
So in this, the method of MTP would be
Dr.
medical.
Medical method of abortion.
I think nowadays most of the MTPs are going to be medical methods, right?
MMA.
So this is the checklist I was talking to you about. You can use this checklist to decide whether she is fit for medical abortion or not. Next slide. Which route is preferred? We were talking about. Next slide. This is just to complete the session. All of you have told us. Anybody? Which route is the best route?
Oral. It can be orally. We can give it or sublingually. And
so ideally, vaginally and buccal sublingual are good. Oral efficacy is reduced because of rapid absorption.
Duration of action.
So oral should be not advocated usually. So Dr. Sati, if this not in this particular case, maybe in any other early abortion, you've given her MMA and she comes with a continued pregnancy, what would you do?
Because
maybe she was 10 weeks. Yeah, maybe she was just around 10 weeks and she's taken MMA, but her pregnancy continues. What will you do? Dr. Sati, are you there? If not, anybody else?
Termination by surgical.
Yeah. The point here is, do not repeat the MMA again. We want this point to be sent across. Next slide, please. That if the pregnancy continues, you have to go for surgical evacuation. Do not go back for an additional dose. Only if it is a non-viable missed abortion, you can go for an additional dose. If it is a continued pregnancy, do not repeat the dose. Go for surgical method.
What if you have to tell their mind and continues willing to continue the pregnancy?
Yes, you have to tell them prior only that it could be, it could not have any effect on the pregnancy, and when scan is done next, pregnancy would have continued. She cannot continue pregnancy as she's already taken the medical method.
Yeah, because lethal cardiac anomalies, Limbaugh syndrome is one of the common complications following epidural. So you need to tell them that. So she cannot continue the pregnancy.
Yeah, pain management is one thing in any type of abortions, which is very important because it increases anxiety in these women. So how would you manage pain in such cases, Dr. Maya?
I can try.
Yes, Maya, please. You're audible. Maya, you can speak.
Yeah, medical abortion.
We can try any NSIDs. Hello, can you hear me?
Your voice is breaking. Your voice is breaking, Maya.
Pain management can be done.
Somebody else.
Hot water bags, music therapy, or vocal anesthesia. In surgical procedures, we can do a paracervical block by injecting 1% xylocaine at 2, 4, 8 and 10 positions, and we can give tramadol suppository pre-op. IV sedation is ideal, but little costly and needs expertise. And again, general anesthesia is the best.
Yeah. But I think when some patients do request us, sometimes we do have to give them some potent painkillers. So, Dr. Pushpalata, what complications would you anticipate?
Could be incomplete abortion, increase in the bleeding, so sepsis, and during a procedure, if surgical evacuation done, the perforation and late sequelae like adhesions. Importantly, here the patient may end up in a psychological sequelae where she needs psychological counseling too.
Yes, very true. Thank you. So these are, I think, do we have time to, or should we, if you could have just 5 minutes, we will end up the session. Dr. Monica, the host, please. This is just a rapid fire of the other common comorbidities when patients come to us for MTPs. So I think we'll go ahead with this. What would you do in a case of diabetes mellitus? Any one of you?
Diabetes as such is not an indication unless it is uncontrolled with a high HbA1c.
What precautions would you take if she is a diabetic coming for MTP?
Yeah. So hypoglycemia is one of the major problem in these patients. So if the patient is already on insulin, so that the day prior to the procedure, long-acting insulin, only half the dose should be given, and in the morning, no insulin should be given, and it should be scheduled as a first case early in the morning, and good consent should be taken, and post-procedure medication requirement will decrease because the hormones of pregnancy would come down, and we have to counsel them regarding the contraception in the postpartum period, post-abortal period.
Next, hypertension, controlled, uncontrolled. Dr. Pushpa? MTP page coming for MTP with hypertension.
Yeah, we have to control the hypertension using proper antihypertensives. But in case she needs a termination, we can either use a misoprostol or oxytocin. Only precaution we have to take here is we should not use ergotamine drugs. That is, methadone should be avoided whenever we are giving the medication.
So well controlled, it can be MMA in an outpatient setting. If she has comorbidity or vascular derangements or uncontrolled, you may have to do it in a hospital setting. That's the message here. Then a very common scenario, epilepsy. How would you manage a patient who comes for MTP with epilepsy?
If she has a well-controlled epilepsy, then we can manage her with an outpatient abortion care. So, but if she has an uncontrolled seizures or recent onset, then she required a hospital admissions, and we can use a medical management. But she is on a because of an increase in the metabolic P450 system metabolism of the mifepristone, especially if she is on carbamazepine, phenytoin, or phenobarbital. Then we should also counsel her later with the post-abortion contraceptions, considering her usage of anticonvulsant, especially oral contraceptive, to be avoided because if she is on an anticonvulsant.
Enzyme inducers. Yes, ma'am.
Yes, enzyme inducing. Then bronchial asthma is another very common situation. Dr. Sharma?
Yes, madam. In bronchial asthma also, like usually we have a low setting of asthmatic attacks, and if it's not recurrent, we can go in for the usual care itself. But in place of like severe bronchial asthma, she needs to have everyday inhalers. Such a patient, definitely while bringing for her abortion visit itself, they have to bring, that is what we'll advise. And prophylactic use of PGE2, yes, we do not recommend because it can cause for bronchoconstriction. Misoprostol, definitely it's not contraindicated as such. Mifi, well, we can avoid, but only on those patients who are using the glucocorticoid therapy. They are, if that is that too, a systemic bronchial asthma patients, only in those cases. Yeah.
They are a contraindication for mifepristone.
Mifepristone, yes.
Thyroid?
Thyroid, no, ma'am. Thyroid, if it's a routine, she just has a hypothyroid cases or anything, we don't have any contraindication to the MMAs. But when it is definitely the hyperthyroidism, we are worried about the thyroid storm. So initially, we have to have a complete control. With the endocrinologist also, you can mobilize, definitely, along with the anesthesiologist, intensivist. And then you go in for the abortion care.
Yeah, so that is why when anybody comes to us for an MTP, taking the clinical and medical history is very, very important, because many of them will not reveal whether they have epilepsy or they have bronchial asthma. Because hypertension we may detect, diabetes we may detect, but epilepsy and bronchial asthma and thyroid, they keep it away unless we dig into the history. Very, very important that we take a meticulous history. So effective post-abortion care for women with such medical problems will reduce pregnancy-associated morbidity and mortality, and hospital-based abortion is recommended for all women with medical conditions. I think that is the take-home message today. Next slide. So let us all join hands in removing barriers to abortion and protect women's lives, health, and human rights. I thank all the panelists. And of course, the need for post-abortion family planning has to be very, very important and stressed to the couple. And we have our expert, Dr. Kasturi Donimat, the president of KASOGA, with us here today. And of course, we all should intend to break the cycle of unintended pregnancy, not forgetting to prescribe post-abortal contraception services in a respectful manner to all these women. Next slide. And the panelists have done a very wonderful job. Next slide. Shema, we can go to the last slide. So I request Dr. Kasturi Donimat, who is here as our expert, to kindly give her comments on all this evening. Thank you.
Shall I stop sharing, madam?
Yes. Yeah, you can stop sharing.
Thank you.
Thank you.
Thank you. Yeah. That was a really wonderful panel discussion. Actually, very what do you tell? Real-time case scenarios, like how.
Madam, these are all real-time cases. All real-time cases.
Yeah, real-time. So it really helps them, like back home, for all the delegates in their day-to-day practice. The inputs from this, the messages, the carry-on messages, they can implement day-to-day practice, because so many will be having so much confusion, if this is the case, what to do. So your carry-on messages are really excellent. It will really make a difference in their day-to-day practice. So they can be confident to handle these cases in day-to-day. So because it's already late, I will not take much time. So thanks to all the panelists for such good, excellent inputs, and Bharti for this excellent panel discussion. Yeah.
Thank you, madam.
If anybody has any doubts, then we can clear. Otherwise, I think it's because we are already late. So
I myself had one is woman coming for MTP after 12 weeks, saying contraceptive failure. And this is where our PCPNDT comes into picture. So, do we offer for contraceptive failure after 12 weeks? Though MTP Act says we have to offer MTP up to 20 weeks, and a single practitioner can decide upon that. So, what is the safety for the practitioner with the present PCPNDT scenario?
no, you can, no problem. If she tells contraceptive failure, it may be. We have to take it as a truth, whatever she tells.
Because we have no evidence. We have no evidence.
We can't ask her for this thing to show the barrier.
Right. It is her right for MTP. We have to give her the services.
She's a third gravida, has already 2 female children, and we don't know the gender of this case. But unfortunately, if this MTP gives a female baby, what is this?
But with proper documentation, madam, isn't that right?
No, we have faced such scenario with one of the doctors, and the police will say you have done it wantedly.
So what I would do in that case, Dr. Swarupa, what I do in that case, when a second trimester abortion with 2 female children comes, maybe they've got a scan done elsewhere and they come because we don't do it, I refer that to the DHO and the RCH officer and the PCPNDT officer. I think we should see that we are not only we are dragged into the legalities, let the administration come inside. It is their job to trace out and find out whether she has got a scan done. So I generally do that. I document, I take her Aadhaar card, and I link it to the district health officer and the PCPNDT officer.
Okay.
I think that's a good job.
That you can do. Good idea. Yeah, you can do that to be more safe.
Yeah, that's more safe. So it's better that they are also there and they come in and intervene in the situation.
First thing is save our skin. So please,
they will run away. When you say this, they will run away, and it's good for us.
No, it doesn't matter. Yeah, it's good for us.
Matter
Yes.
really. Yes.
Yeah, we should be cautious. That is it.
Yes. Yes.
So, Dr. Monica.
Thank you, ma'am. Thank you, Bharti ma'am, Girija ma'am. That was
you.
an excellent panel.
Thank
Thank you to all the panelists for the excellent point, precise take-home messages, I would say. Thank you, ma'am. So I would now request Bharti ma'am to give the vote of thanks, please, ma'am.
Yeah, thank you, Dr. Monica. Well, thanks is a very small word, but expressing gratitude is my duty today. And I think education in this way, learning and unlearning and relearning, is the way forward to carry this torch of public awareness to all the women of India for the betterment of their health. I thank the Dr. Rishikesh Pai, President of FOGSI, for giving us this opportunity to be on this panel, on this platform today. My extreme gratitude to Dr. Priyankur Roy, the young Turk of FOGSI, who is the chairperson of the Public Awareness Committee. Thank you for having us all here. I thank Dr. Jaideep Tang for that wonderful overview of the present scenario in the MTP and the confusions and the legalities, the controversies involved. Thank you, sir. I thank Dr. Sampath Kumari, Vice President of FOGSI, Dr. Charmila. I thank Dr. Vidya Tobi, Dr. Shobha Gudi for being with us today. I thank Dr. Kasturi Donimat, our beloved President of Kasoga, for being with us today. I thank Dr. Rekha Rajendra Kumar and Dr. Raghavendra Prasad, who were the conveners, the moderators of the first panel on MTP. And I thank Dr. Monica, who has been the backbone of this whole public awareness program. She is there morning, afternoon, night, midnight, sometimes at 1 o'clock. I am there in the emergency. I put a message. She's immediately replying to that message over there. I think she doesn't sleep at all. Monica, you've done a wonderful job. And I thank all my co-panelists for being so enthusiastic and made my job easy. And I'm extremely sorry for the technical glitches because of an emergency in the hospital. I would fail in my duty if I do not thank the corona, not the coronavirus, but the corona pharma, who have been most very, very helpful in providing this platform for the Public Awareness Committee. And I think in the coming days, we will be using your platform. Thank you very much. Wish you all a safe good night and a safe weekend. Have a healthy weekend and do de-stress yourselves and take a day off on Sunday. That is, thank you very much.
Thank
you.
It was wonderful.
Thank you, ma'am, for the excellent coordination you and Raghavendra sir have given us for the South Zone societies. I and Shatabdi are indebted for your cooperation also, ma'am. Last but not the least, we would request all the societies to participate in the FOGSI MCure Anemia Initiative, which the dates have been extended from the 1st March to 15th of March. So if your society has not yet enrolled, kindly enroll with the name of the president or secretary and the date that you're going to take in. I'm sure together.
There is one doubt. Can we do it on 4 days or can we do it only on a single day?
Sure, ma'am. We can do it on spaced out in 2 or 3 days also, ma'am. No issues.
Fine. Yeah, we wanted to know that.
We need a number of 400 to 500. We can space it out and do it, ma'am.
400.
Yes.
Yes,
The
ma'am.
local MCure person, madam. The local MCure person, when they come to meet you, madam, you can discuss the days. They are willing for. They are willing for many days, like 4 days.
We have already done that. The local person has come and we have already enrolled and we have told him on 4 days.
Absolutely.
Thank you.
Okay.
Thank you so much, ma'am. Thank you, Shatabdi, for being there and covering up everywhere.
Thank you, madam.
Thank you.
Thank you.
We are extremely sorry for the hiccup in the initial phase for the link at least, but technical errors do happen. Nevertheless, the program has gone well. Thank you so much.
Really well. Thank you all.
Thank you. In our hospital, we had an acute myocardial infarction of a young boy who came into the casualty and died. So that was the whole ruckus which was going on in the background.
Yes, ma'am.
Sorry about that.
No problem. Part and parcel of a government job, ma'am. Can't help it.
No, this is a private sector, not government job. I'm in the private. This is in my hospital.
Okay.
It happens even in private. Don't think it happens only in government. No, they were not creating any mob violence. They were upset because of the sudden death. So they were mourning. There was no galata. It was only mourning. because
Okay,
it was a
morning.
sudden,
Okay,
young
ma'am.
fellow came with, just came, was referred for an ECG, and by the time he came, he had a cardiac arrest
Oh.
as the ECG was being done.
What was the age, Bharti?
26 years, madam.
Sorry, Bapre.
26. So, Yaro general practitioner note bitu, they have sent him here to go and get ECG done. Anta. By the time he came here and they were just taking him into the hospital, he had a cardiac arrest.
No risk factors.
I don't know, madam. I didn't ask her. He's a Muslim boy, ante, so I
Now
thought
it has
maybe
become a thing of the day, no? Sudden
lifestyle,
death.
smoking.
Sudden death in young has become thing
Smoking
of
is
the day
very,
now.
very common in that age group.
Post-corona also, they are saying it is slightly on the rise in the younger.
Exactly. Post-corona.
Yeah. Very dangerous.
Thank you, madam.
Yeah,
Bye-bye.
Thank you. Bye-bye.
Enjoy your weekend.
Thank you.
Yeah,
It was wonderful. Thank you, Priyanku and Bharti. It was a wonderful panel. Seeing
Thank you,
Rupa,
Dr. Vidya.
Kasturi, Shama, Monica.
Thank you,
much
Vidya.
that we enjoyed the panel.
Yeah,
Thank you.
thank you very much.
Thank you, ma'am.
madam. Thank you.
Thank
Thank you. Bye-bye. Good night.
એ ભાઈ હવે મને એક
Thank you so much, ma'am. Angel this side. Dr. Monica.